online webinar လေးကိုတက်ရောက်လာတဲ့ Microbiology ဆရာဆရာမများနဲ့ Laboratory ပြီးက Medical Technology နဲ့ Lab Technician များအားလုံးမင်္ဂလာပါရှင်။ကျွန်မကတော့ဒီ webinar လေးမှာ MC အဖြစ်နဲ့ဆောင်ရွက်သွားမယ် Biomaria Application Specialist ရှင်းသက်ဖြစ်ပါတယ်ရှင်။အဲ့တော့ဒီနေ့ပွဲလေးကိုအပိုင်းတစ်ပိုင်းခွဲပြီးတော့ရှင်းပြမှာဖြစ်ပါတယ်ရှင်။နောက်တစ်ပိုင်းမှာတော့ Way to manage fat in urine and sputum ဆိုတဲ့ခေါင်းစဉ်အောက်မှာအတန်လေးကိုမြှုပ်ပေးပါလား။တစ်ပိုင်းမှာတော့ way to manage fat in urine and sputum ဆိုတဲ့ခေါင်းစဉ်အောက်မှာ urine နဲ့ sputum မှာပေါက်တက်တဲ့အကောင်လေးတွေကိုဘယ်လို manage လုပ်ရမလဲဆိုပြီးတော့အစားအဆုံးဆွေးနွေးတော့မှာဖြစ်ပါတယ်ရှင်။ဒုတိယတစ်ပိုင်းအနေနဲ့ကတော့ဒီ vitamin 2မှာဖြစ်တတ်တဲ့error လေးတွေအကြောင်းကိုဘယ်လိုဘာကြောင့်ဖြစ်တဲ့လဲဘယ်လို troubleshoot လုပ်ရမလဲဆိုတဲ့အကြောင်းအရာလေးကို Mr. Brad Foley ကနေပြီးတော့ဆွေးနွေးတော့မှာဖြစ်ပါတယ်ရှင်။ Mr. Brad Foley ကတော့ဒီ ASEAN ရဲ့ Biomaria ရဲ့Senior Regional Scientific Support Manager ဖြစ်ပါတယ်ရှင်။အဲ့တော့အချိန်ကလည်း9 နာရီဖြစ်တဲ့အတွက်ကြောင့်မလို့speaker ဖြစ်တဲ့ Mr. Brad Foley ကိုဖိတ်ခေါ်မှာဖြစ်ပါတယ်ရှင်။ I would like to invite Mr. Brad Foley to speak and to discuss the way to manage fat in urine and sputum.
Okay, good morning, everybody. I hope you can hear me. Do I need to take my speaker off here? Yes, please. I will now try to share my screen and check that everything's okay so that we can start on time. Can you confirm that you can see my screen and can hear me okay? Okay, good morning once again. I'm broadcasting today from Okatiri offices. Okay, it sounds quite strange, but true. Okay, so I'm going to be discussing 3 topics this morning. So it's quite in depth. We'll be talking about urine cultures and sputum cultures in detail, often because we have a lot of questions, particularly regarding what to distinguish between pathogens and normal flora, particularly for lower respiratory tract specimens. And then earlier, you were sent out a survey regarding what type of questions or problems or issues that you were having. And then I will address all of those questions, or at least the majority of those questions, after we talk about urine and sputum cultures, okay? So we're going to dive quite in detail, and hopefully this will help you. Along the way, if you have any questions or anything like this, can you please put it in the chat? We will have people monitoring the chat, okay? And hopefully we can answer your questions either at the end of each topic or along the way, okay? So it's quite strange to be unidirectional, talking without seeing anybody or anything like this. So my reference for both the urine cultures and also the sputum cultures is the Clinical Microbiology Procedures Handbook. This is the 5th edition from last year, so it's the most up to date. And this is issued by the American Society of Microbiology, okay? So I'm not using a corporate procedure or anything like this. I'm using an international third-party procedures, okay, to give you a completely impartial view about what we're aiming to do for both urine cultures and sputum cultures, okay, or low respiratory tract cultures. Okay. Jumping right in, and I will check my time as we go along. Urine cultures first, okay. It is the most frequent specimen in the bacteriology laboratory, typically, okay. About 80% of them coming from females, purely due to the anatomy, nothing unusual there, okay. Now, urine is normally considered to be sterile until we urinate, where it picks up genital flora, okay? And here we want to diagnose things like cystitis, pyelonephritis, etc. Purely, we can easily treat urinary tract infections with routine antibiotics, okay? And we can normally treat effectively within 48 hours, unless we have a complicated urinary tract infection. So as mentioned earlier, the urinary tract is normally sterile, and a urinary tract infection is an attack on the urinary tract tissue by one or more microorganisms, typically one usually, and never usually more than three, okay? Generating an inflammatory response with leukocyturia and symptoms that vary in type and intensity depending upon the site of the infection. For female urinary tract infections, the most common pathogens that we have is E. coli. You're probably quite aware of this already. So typically, according to one study, we detect E. coli in about 77% of the cases, okay? Other pathogens that we might detect in a female urinary tract infections include Proteus mirabilis, around 7%, Klebsiella species, around 3%, other Enterobacteriaceae, which has now been renamed to the Enterobacteriales, okay, about 4%, Staph saprophyticus, about 3%, and other pathogens around 6%. As compared to male urinary tract infections, the primary pathogen again is E. coli, but slightly reduced about 46%. Also, we have Proteus mirabilis around about 6%, Klebsiella pneumonia 6%, Pseudomonas species around about 6%, along with Acinetobacter 6%, other gram-negative organisms 14%, Enterococcus species around 9%, and other gram-positives around about 7%, okay? So the primary takeaway here is for both male and female, the predominant pathogen is E. coli in both cases. Right, we can have different types of urinary specimens. We can have an early morning collection, midstream collection is very, very common, okay? We can have a suprapubic aspirate here. We can have a straight in and out catheterization specimen. We can also have indwelling catheters and ileal conduits. And it's always advisable, not always possible. We'll talk about the theory and the practical. I come from the real world. I come from where you are coming from right now, so I completely understand reality as opposed to theory. So it's ideal to deliver a urine within 2 hours. And if it's not possible, it should be refrigerated at 2 to 8 degrees, okay? Longer than 24 hours delivery to the laboratory, we have a preservative that we can add as well. On delivery to, the other things that we might have is dip slides, perhaps not so common here in Myanmar, but particularly if urines are collected in collection centres away from the main institution, hospital or laboratories, a dip slide is actually a very practical way of collecting the urine. But be aware that the dip slide, first off, it can start growing the bacterial colonies while it's being transported. And this is an advantage where very often that on receipt of the dip slide to the laboratory, we already have the colonies growing on the two sides of the agar. Once we receive the urine in the laboratory here, we check for the quantity, the color, turbidity, and very often we do a dipstick. A dipstick can have a range from about 6 to 12 different biochemical tests. And the common biochemical tests that we are usually looking for, if I get my pointer, protein, albumin, pH, leukocyte esterase, hemoglobin, glucose, ketones, nitrate, and there may be more depending upon the choice of your dip slide. Typically, we would do then the enumeration and morphology of the urine. This can be done either manually or automated. I was visiting quite a few laboratories in the last 2 days, and I was very pleasantly surprised to see that many of the laboratories had automated urinalysis. Okay, so I can see that really, despite everything, Myanmar is really still developing quite rapidly. Okay, so there's two different methods of doing enumeration and morphology. So this is either using a microscopic examination manually, and one of the common methods here is using a COVA slide here. This is a disposable slide or a counting chamber, if you want to call it. It's plastic, it's a one-time usage, and here we can enumerate the different cellular components, or as some of you have, a automated system already. Okay, so here we're looking for different cellular components such as the red cells, the white cells, epithelial cells, different types of crystals to indicate what type of metabolic situation the patient has at the moment, and whether there's any casts or not. Regarding the bacterial counts, okay, so it's very important to enumerate the bacteria, and there's two different ways that we can do this, either with the manual microscope or the automated method, or we can also enumerate with the colony forming units by using a calibrated loop. So any of those methods is okay. Now, clearly, when we report urinary tract infections, any colony count of greater than 10 to the power 5 indicates that we have a most probable urinary tract infection. Colony counts of less than or equal to 10 to the power 3 usually indicate that we have contamination. And we have a grey area of around about 10 to the power 4, where we still need to identify the organisms and put out susceptibility results. And here it is a possible urinary tract infection, and it depends upon the clinical symptoms whether the clinicians should act upon this or not. Regarding the media for urines. Now, I know in Myanmar, we're very often using the basic media, but I still want to inform you about what is available worldwide, okay, for future development, etc. It's very, very common worldwide, and not only in Myanmar, to use two media, typically a blood agar plate. We highly recommend a Colombia-based media here rather than a trypticase soy media. The only reason is because it contains a more variety of proteins and therefore will grow a greater variety of organisms. So a blood agar plate, a Colombia blood agar with sheep blood, whether it is homemade, which is quite typical here in Myanmar, is no problem. And this is designed to grow all of our urinary tract pathogens, which includes our gram-positives, our gram-negatives, and our yeast, okay? An alternative, which I like, which I will explain, is a Colombia CNA agar, and a Colombia CNA agar is going to inhibit our gram-negative organisms. CNA stands for cholesterol-nalidixic acid. Therefore, if we use a Colombia CNA agar plus a McConkey will only grow our gram-positive, gram-negative organisms, and the CNA agar plate will only grow our gram-positives, and therefore reducing the need to do gram stains, okay? So the CNA will grow our gram-positive, which does include our yeast. Other media, which is available, whether it be homemade or commercial here, we do have some chromogenic media of various brands, so I'm not here to sell you anything, okay, just to inform you. But another one which is perhaps designed specifically for urines and is also readily available in different brands, in dehydrated and ready-made media, is the Cled agar. The advantage of the Cled agar, it is one agar plate as opposed to two. So therefore, it reduces the cost by half, okay? And it can grow both our gram-positive, our gram-negative organisms, our yeast as well, but it's designed to inhibit the swarming of proteus. So it makes it much easier to pick up our colonies, etc. In addition, sometimes we get requests for TB cultures in urines as well, but this is a rare occurrence. I'm taking this directly from the clinical procedures manual as well. So there's examples of alternative urine culture systems that are available on the market as well. So these are some dip slides, which I mentioned a little bit earlier, coming from different brands or manufacturers here. So we have the Dia slide from Novamed, and that's manufactured in Jerusalem. That can have usually a dip slide has two agars, one on each side of the paddle. Could have a CLED and MAC on one side, CNA and MAC on another slide, and a UriSelect 3 and MAC on another one. Okay. We also have the dip and count from Starplex Scientific in Canada and the UriCult from Orion in Finland as well. So just to let you know that there's more options than your standard blood and McConkie. Two main ways for inoculating the urine specimens are for enumeration. So for inoculation, for voided urine specimens and those from indwelling catheters, inoculate the media with at least 1 microliter. So there's two volumes that are recommended by the clinical procedures manual, either 1 microliter or 10 microliter for enumeration. It's very, very common to inoculate with 10 microliters, okay? But both are acceptable. For other urine specimens collected by sterile techniques, inoculate at least 10 microliters, and we inoculate particularly the blood agar plate by using a calibrated loop and streaking down the center like this here, and then we want to cover as much as the plate as possible by streaking back and forward. Now, alternative method, which I think is very far less common, is by using a pipette and dispensing either 1 microliter or 10 microliters onto the plate, and then using a sterile spreader to spread the colony all over the plate. Okay. I think that takes longer and it requires either disposable spreaders or reusable spreaders, depending on what's available. So procedure B is much less common around the world. Incubate plates in ambient air at 35 to 37 degrees Celsius. And if it is convenient, we can incubate our blood agar plate in 5 to 7% CO2 to enhance the growth of our gram-positive organisms here. It is not normal to do anaerobe cultures, but these are done on request or a suprapubic aspirates, or when we have a enteric fistula is suspected. We examine the cultures of our plates after 12 to 18 hours. We don't typically need to incubate for 48 hours, except for the following conditions, okay? The specimen was collected by an invasive technique, such as a suprapubic bladder aspirate or a straight catheter method. We have tiny or very small or scant colonies that are barely discernible after our 12 to 18 hours incubation or our overnight incubation, or the culture results do not correlate with our gram stain finding or clinical conditions, okay? Or the patient is immunocompromised, including patients that are organ transplant recipients, okay? Or perhaps we suspect a yeast is the cause of infection and the yeast has not grown up after 12 to 18 hours. So the majority of the plates we can discard after an overnight incubation. So typically yeast grow well on our routine media. and are common colonizers of urinary tract and are not often associated with invasive infections. So be careful about over-reporting yeast from urine specimens, okay? So typically they are colonizers and not normally the cause of our urinary tract infections. When we examine the cultures here, we examine the media for our quantity and morphological type. So typically, if we're using a 1 microliter loop, then one colony represents 10 to the power 3 colony forming units per mil. And if we're using a 10 microliter loop, which I think is more common, then one colony represents 100 colony forming units per mil. And we determine the colony count of each different morphotype. That means each different type of colony in the culture separately. We'll have coming up, okay? And these are the figures from the clinical procedures manual directly. To determine whether we need to work up, that means to do the identification and susceptibility of the different colony types, okay? Do not identify normal flora to the genus or the species level unless growing over the threshold, and the threshold is 10 to the power 5. Normally, we identify clinically significant growth over the threshold, that's 10 to the power 5. Anything less than 10 to the power 3, we do not need to do identification and susceptibilities of, and we could put out a result of mixed normal flora at 10 to the power 3 colony, less than or equal to 10 to the power 3 colony forming units per mil. We also look for any beta hemolytic colonies consistent with strep A galactiae, and this is particularly important from females of childbearing age as well. They need to be cleared of the strep A galactiae, particularly if they are trying to become pregnant, okay? We perform susceptibility as indicated in the tables, and we hold positive culture plates for at least 2 to 3 days, or ideally 7 days after we report the results in a perfect world. But this also depends upon the facilities, whether you have the capability of holding plates or not for up to 7 days, to allow the clinicians to receive the results, act on the results, or question the results, okay? And we hold the urines refrigerated for at least 48 hours in case there's any feedback from the clinicians or in case we need to resolve any problems. So there is chromogenic media. And the advantage of the chromogenic media, I know it is new in this part of the world, okay, is that we can reduce the time to reporting and we can reduce the cost of reporting as well. Now, some chromogenic media are designed to directly identify particular organisms. In this case, the Chrome ID, as an example, but there is other examples available on the market as well, can directly identify E. coli, this being the predominant pathogen that we have for both male and female urinary tract infections, okay? And with this, if we identify E. coli, it is red to burgundy color colonies, and we do not need to perform a follow-up identification. If you're using, for example, a Vitek 2, you do not need to use an identification card, okay? It can also presumptively identify other organisms such as enterococci, which will be turquoise to pale blue to green in color. The Proteus species will be dark brown, and the KESC group, which stands for Klebsiella, Enterobacter, Cerati, and Citrobacter, will be blue to green in color. Okay. We can also do enumeration on all plates, including the Chrome ID CPS here. And if we're using a 10 microliter loop, calibrated loop, Whether it is reusable or disposable, it doesn't matter, okay? Then the cutoff is 10, 100, okay? So if we have less than 10 colonies growing on our plate, then we have less than or equal to 10 to the power 3 colony forming units per mil, okay? If we have greater than 100 colony forming units, then we have 10 to the power 5 or greater colony forming units per mil. And if it's between 10 and 100 colony forming units per mil here, then we have 10 to the power 4. Now, it doesn't necessarily need to be counted one by one. Just a quick glance to see whether we have less than 10, and I think we can clearly see that in this example we have 1, 2, 3, 4, 5, 6 colony forming units. And here, if I take a quick glance, I probably have 10, 20, 30, 40, 50, 60, 70 or 80 colonies here. So I do not need to individually count, but just take a quick glance to see whether it falls less than 10 or greater than 100, okay? Anything more than 10 to the power 5 is considered significant. Some of the presumptive identifications with the CPS Chrome ID. So E. coli, as we mentioned earlier, is the red to burgundy color here. And if we have red to burgundy colonies, we do not need to do identification here. We can simply report immediately that we have E. coli, saving time and money in not performing a further identification method. For the other organisms, it is a presumptive identification. So you can see some of the color formations here for Enterococcus faecalis, Klebsiella pneumonia, Serratia, Proteus, Mirabilis and vulgaris, Staph saprophyticus, and Agalactiae. So, excuse me. So with one plate, we can put out approximately more than half of our results immediately if it is E. coli. CLED-agar is another alternative. CLED stands for cysteine lactose electrolyte deficiency. And the advantage of this, it was designed specifically for urine samples here. And here, the Proteus organisms will not swarm. So we'll have discrete colonies for all organisms, and it will make it very much easier to pick up. It will also differentiate our lactose fermenting organisms, which will be yellow, from our non-lactose fermenting organisms, which will be a bluey green in colour. It will grow all of our organisms, both the gram-positives, the gram-negatives, and our yeast as well. Typically, you'll be using a blood agar plate, preferably Columbia-based, okay? And here we're looking for hemolysis as well as enumeration. And this is the isolation of our more fastidious organisms, such as streptococci or Listeria. Using CNA, as I said, personally, I've used CNA historically, and I really like it because it inhibits all of our gram-negative organisms here. And this is due to the addition of nalidixic acid and colistin here. And it makes it like a gram stain. If I'm using both a McConkey and a CNA plate, then on one plate I have my gram-negative organisms, on the other plate I have my gram-positives. And it's reducing the time to reading and follow-up tests as well. Just to remind everybody about hemolysis reading, we have beta hemolytic colonies which have a clear halo around the colony. An example here is Streptococcus group A or Streptococcus pyogenes. We have alpha hemolytic colonies which have a green halo or known to have partial hemolysis here. And a classic example is Streptococcus pneumoniae. And then we have our gamma hemolysis or no hemolysis, where we have no clearing of the red cells. Examples including Neisseria and Enterococcus faecalis. And of course, for McConkey's agar, which I know you've all been using forever, for all different types of specimens here. Here it's used to only grow our gram-negative organisms and to differentiate between our lactose fermenters and our non-lactose fermenting organisms. Now, this is a plate coming from the Clinical Procedures Manual directly here, and this is showing us the colony growth on both our McConkey and our blood agar. So we have blood agar on the top row here, and we have McConkey on the bottom row here. And this is showing us a typical growth of greater than 10 to the power 5 for our very common urinary tract organisms. E. coli will grow both on our blood agar and our McConkey here. And these plates were inoculated with the 10 microliters as well. Enterococcus faecalis should only grow on our blood agar and not our McConkey. If it does, there's something wrong with the quality of your McConkey agar. Okay? Same with Staph saprophyticus, only growing on our blood agar, not the McConkey. And if we have a contaminated specimen, so you can see here a contaminated specimen, even though it's greater than 10 to the power 5, it looks like we have at least 3 different organisms here, and we should not follow up by performing identification nor susceptibility of these colonies here. And if we have insufficient growth here, we have less than or equal to 10 to the power 3 colony forming units per mil. So either contaminated specimens or insignificant growth, we should not follow up by performing identification and susceptibilities. So thresholds for reporting coming from the Clinical Procedures Manual. So the most common specimen is a midstream urine or clean voided urine here. And the media they recommend here is a blood agar plate and a McConkey here. So that's probably what you're doing nowadays, and that's absolutely correct. There's nothing wrong with that. And here, only report 1 or 2 urinary pathogens at greater than 10 to the power 5 colony forming units per mil. If there is more than 2 different colonies on the plates here, then do not follow up, do not report. It is contamination and report as mixed normal flora. Okay, you can inoculate the plates with either 1 microliter or 10 microliters, so both are acceptable volumes here. And the threshold for reporting, as again, is greater than 10 to the power 5 colony forming units per mil. If we're looking at other specimens here, it is slightly different and slightly lower thresholds as well. So if we're looking at catheter specimens here, it is the same plates. We're only looking at 1 or 2 different colonies here to report. But the threshold here to report is 10 to the power 4 to 10 to the power 5. Okay, so it's slightly lower. And a suprapubic aspirate, they recommend for suprapubic aspirate here to add an additional chocolate plate here. So pathogens, common pathogens that we always must identify and report include any gram-negative organism if it meets or is over the threshold of 10 to the power 5 colony forming units per mil. So any gram-negative organism, Staph aureus, Enterococcus, any beta hemolytic streptococcus, and of course Neisseria gonorrhea. So for Neisseria gonorrhea, it's very common to report the identification after we have confirmed it here. It's not common to report the susceptibilities for Neisseria gonorrhea unless it's requested. And for yeast here, usually we can report just the identification, at least to the genus level, and the susceptibilities are optional. Emerging pathogens, so these are ones that are appearing more and more frequently, including Aerococcus, Urine, Actinogenum, having trouble pronouncing that, Charlei, and Alloscardovia, omniocolons, at least report to the identification level, but susceptibilities are not required. Contamination here. So Streptococcus viridans here, we report as strep viridans and do not need to do susceptibilities here. Neisseria, which are not gonorrhea or meningitis here, we report as non-pathogenic Neisseria, no need to do susceptibilities. Gardnerella vaginalis here, we report as Gardnerella vaginalis, and there is no need to do susceptibilities. I had that question from a laboratory yesterday as well. Corynebacterium, we report only urease positive Corynebacterium, no need to do susceptibilities. Lactobacillus species, again, we just report as Lactobacillus species, no need to do susceptibilities. Staphylococcus, which are not Staph aureus, we only perform identification and susceptibilities on the following staphylococci, which includes Staph saprophyticus, Staph fluginensis, Staphylococcus intermedius, Staphylococcus schlepperi, and any other staph we report as normal flora. Now, coming from the clinical procedures manual, so I felt I need to show you. They have reporting scheme for presumptive identification of the main pathogens from urine here. And this is the very, very minimum, but I know that many of you have more accurate means of identification and performing susceptibility, such as the VITEC 2, which is the preferable way if you have it. Urine susceptibilities here. So again, the choice of antibiotics, we look at the CLSI M100, and I'm always using the most up-to-date documentation. So this is the 34th edition coming from this year. For those that may be less familiar, for the enterobacteriales, keep in mind that they changed the terminology, or they added 7 more genuses to the Enterobacteriaceae to make the enterobacteriales here. About 5 years ago, they changed the terminology. Now, this year, they also changed the table that you're seeing here for the choice of antibiotics for the enterobacteriales, and now they're calling it Tier 1, Tier 2, Tier 3, and Tier 4. Now, the reason for the tiers is for antimicrobial stewardship, or for guiding the clinicians to use, where possible, the most common antibiotics, which are more cheaper if the organism is susceptible. So typically we're looking at our urine-only antibiotics down here. So we have cefazolin, which is a surrogate for uncomplicated urinary tract infections, and nitrofurantoin, which are under Tier 1. So Tier 1 must always be tested and reported, plus a selection of Tier 2 antibiotics, okay? There's no urinary Tier 2 antibiotics here. Then we have Tier 3 and Tier 4. Tier 3 and Tier 4 antibiotics are used as reserve antibiotics. They are usually tested and reported when Tier 1 and Tier 2 antibiotics are resistant. So here we have our fosfomycin, and this is only to be reported for E. coli. For our non-fermenters, for example, Pseudomonas aeruginosa, we can add on our amikacin here for urinary tract infections here. And there's no Tier 3 or Tier 4 recommendations for urinary tract infections for Pseudomonas. For Acinetobacter, we can report our tetracyclines for urines as well. And there is, again, no Tier 3 or Tier 4. For Staphylococci, nitrofurantoin, again, is the recommended course. No Tier 3 or Tier 4 recommendations. And for Enterococci, we have nitrofurantoin, again, as Tier 1. Ciprofloxacin, levofloxacin as Tier 2, and then on reserve alphosphomycin and tetracycline. Now, there is a new terminology in the CLSI M100 S34 here, and it has an intermediate category with a claret. Now, a claret is this symbol here. And seriously, every year when I get the new CLSI documents, I read it word for word from front to back. And I know that many of you just skip to the breakpoints without reading any of the comments, but that's what I'm here for, right? To remind you of all of the things that we should be aware of, okay? Now, they have a comment regarding the intermediate category with a claret, and it says, note, an I intermediate with a claret in table 2. Table 2 is the breakpoint tables, indicates that agents that have potential to concentrate in the urine, okay? The I claret is for informational use only, and the decision to report the I claret is best made by each laboratory based on institutional specific guidelines and in consultation with the appropriate medical personnel. Okay, the I category also includes a buffer zone for inherent variability in the test method, which should prevent small, uncontrolled technical factors from causing major discrepancies in interpretations, especially for drugs with narrow pharmacotoxicity margins. Okay, so the recommendation is to always report those antibiotics with an I claret. You do not need to report actually I claret, just an I, because these will be useful for the clinicians to use if any other antibiotic is resistant, okay, because they concentrate in the bladder. So here we can see an example, the ampicillin, for example, for, I think this is for the antibacterials. We have here a breakpoint of 16 micrograms per mil with a claret site next to it here. And if there was no other antibiotic to treat the patient with here, ampicillin could be a useful option if it was intermediate. Also, another example is the amoxicillin clavulanic here, and also the ampicillin sulbactam and the cefazolane tazobactam down here. Keep in mind the comments. For ampicillin here, it says breakpoints when oral ampicillin are used are only for therapy of uncomplicated urinary tract infections due to E. coli and Proteus mirabilis. Be aware of the intrinsic resistance or the natural resistance. So this is just to remind everyone. And now if you're using a Vitek 2, of course, this is built into the software of the Vitek 2, and the software or the AES specifically will be looking for this, so you don't have to be aware of it. But if you're using other methods, to be aware of the intrinsic resistance, where an organism cannot be or should not be reported as more susceptible. Okay. Reporting the results. Now, this is following exactly from the clinical procedures manual, and I will put my own take on this in a minute. Okay, so according to them, negative results is if there is no growth observed on all of the media that you inoculated, and we simply report no growth. Me personally, I prefer to report no growth after 24 hours or after the incubation period that you choose, okay? Positive results report insignificant, that's below the threshold, that is less than 10 to the power 3 colony forming units per mil of urinary pathogens or non-urinary pathogens, and they suggest to report a statement such as clinically insignificant growth based on current clinical standards. Me, I will report less than 10 to the power 3, maybe normal flora or mixed flora. Now, report growth of 3 or more distinct species over the threshold, this threshold being greater than 10 to the power 5 colony forming units, as quote from them, growth indicative of pluriurethral, enteric, gram-positive or mixed bacteria, microbiota, possible contamination, suggest appropriate recollection with timely delivery to the laboratory if clinically indicated. Now, this is a bit of a mouthful. I would not report something so complicated. So I would report something a little bit more simpler so that all of the clinicians understand. So I would probably say greater than 10 to the power 5, mixed genital flora, okay? And then as a possible contamination, suggest recollection if clinically indicated. Report quantity and the identification of 1 or 2 urinary pathogens over the threshold that is more than 10 to the power 5. So never report more than 2 pathogens for a urine, followed by the susceptibility results as appropriate. One of the notes is report the quantity in increments rather than specific number. That means report 10 to the power 3, 10 to the power 4, 10 to the power 5, or less than or equal to 10 to the power 3, greater than equal to 10 to the power 5. We do not need to go into more detail than that. If there is unusual findings, and some of the unusual findings from a urine, including growing Neisseria gonorrhea in a pediatric sample, or Salmonella species or Burkholderia malai, directly and immediately to the clinicians. The interpretation, and this is directly coming from the Clinical Procedures Manual again. So the criteria of 10 to the power greater than or equal to 10 to the power 5 colony forming units per mil for significance can be applied to the majority of urine specimens. And this is literally the threshold for reporting 1 or 2 colony types, but may represent asymptomatic bacteriuria. So results should be correlated with the patient's signs and symptoms, but this is the clinician's job, okay? The laboratory's job is to report what they see, and the clinician must always interpret the results coming from the laboratory based on their diagnosis and the patient's symptoms and signs. A mixed culture in an uncomplicated outpatient population indicates contamination here, and low levels, that means less than 10 to the power 4 colony forming units per mil of organism commonly found on the skin and genitalia are generally considered to be contaminants. Okay, so be careful, do not over-report. Colony counts of less than 10 to the power 5 colony forming units in a clean voided specimen in the presence of dysuria and symptoms of a urinary tract infection may be significant here. And this is why we tend to report identification and susceptibilities if we have a pure culture of greater than 10 to the power 4 with the comment as well. And usually the comment is possible urinary tract infection or possibly urinary tract pathogen, okay? Urinary pathogenic bacteria most commonly cause of acute and chronic prostatitis, but skin flora such as coagulase negative staph and Corynebacterium may be found in low numbers in prostatic secretions from chronic prostatitis patients here. And Neisseria gonorrhea is found infrequently, but has been reported as a cause of acute prostatitis as well. Limitations, so for any procedure anywhere, there's always limitations. We can have false negative results, that means to no growth or lack of growth due to pre-treatment with antibiotics or the presence of interfering substances or diluted urine or a low urine pH. We can have false positive results due to bacterial overgrowth or processing of urinary specimens, or if it's delayed beyond the 2 hours and unrefrigerated, or there is no preservative added, or if it's over 24 hours or over 48 hours for a preserved urine. We can also have atypical course of infections. such as due to mycoplasma, ureaplasma, and mycobacterial infections. So these should be considered when we have sterile pyuria. So sterile pyuria is defined as symptoms of a urinary tract infection, and we're getting no growth in routine cultures. Mycoplasma genitalium is associated with urethritis and cervicitis, and molecular testing is recommended if it is at all possible, okay? Particularly in cases of persistent infection. Mycoplasma hominis and ureaplasma have been linked with urogenital infections, but the current guidelines do not recommend testing for these organisms routinely unless we have sterile pyuria and repeated cultures are not growing any of the routine pathogens. So that is what I have for urinary cultures, okay? And I am slightly early according to our schedule. So I'm just going to check with our teammates here. Do we have any questions in the chat box that we need to answer at this stage? I will just go on mute so some.
Hello. Urine နဲ့ပတ်သက်ပြီးတော့မေးစရာမေးခွန်းလေးများရှိလို့ရှိရင် unmute လုပ်ပြီးမေးလို့ရပါတယ်ရှင်။ရလို့ရှိရမှာတော့ရလို့ရှိရမှာတော့မေးစရာမေးခွန်းလေးများရှိလို့ရှိရင် unmute လုပ်ပြီးမေးလို့ရပါတယ်ရှင်။
Kimyanera, Parami Hospital. Yeah. Hello?
ကဲမေးပါရှင်တိကျ
I just want to ask one question, please. The question, my
Teacher,
question is on the anaerobes.
Yes.
Yes.
တိကျ unmute လုပ်ပြီးမေးပေးပါလားရှင်အတန်မကြားလို့
Unmute.
တိကျ unmute လုပ်ပြီးမေးပေးပါလားရှင်
ဒီကျဟို mic လေးပြန်ဖြုတ်ပေးပါအောင်ရှင်
So, urine cultures. What sort of anaerobes, name of anaerobes encountered in the urine cultures? Shall I ask for that?
Or what type of anaerobe participate in the urine culture?
Then, yeah. Name of the anaerobic organism.
Okay, so it's quite surprising, but it's quite surprising, but it's possible to have a urinary tract infection with an anaerobic organism. But typically, we don't culture for anaerobes routinely unless we have a sterile pyuria on the first collection, okay, and the request for anaerobes. Now, with any type of anaerobe, it's possible to have a urinary tract infection, okay, whether it be gram-positive or gram-negative, okay. Most commonly might be a bacteroides, but it's possible to have any gram-positive or gram.
Let's mention about the Foley's catheter. Foley's catheter to retain the anaerobes, not from the routine urine culture. It's anaerobes from the Foley's catheter. Are bacteroides common in urine culture?
Yes, so it's very, very rare to have a request and to follow up with anaerobes for a urinary tract infections, but it is possible to have a urinary tract infection due to an anaerobe as well, including commonly with our Bacteroides, but it's possible for any gram-positive or gram-negative anaerobe. Routinely, I would never set up an anaerobe plate unless you are specifically requested.
Yes, yes. We usually don't do the anaerobic cultures in our lab. That's why for future, shall we have to set up or not?
I would say this is an additional service, a non-routine service that could be offered by the laboratory, okay? But it's certainly not the priority service to offer from any laboratory, okay? So if I'm talking anaerobe, so historically or previously I've given an anaerobe workshop in Myanmar, and of course we need to do more to spread the word around, okay? So if I'm looking at anaerobe culture, I'll be looking primarily at our other sterile specimens first. I'll be looking at our blood cultures, our CSF or other sterile fluids, and I'll also be looking at deep-seated pus, so deep abscesses and stuff like this, okay? So the lowest priority I will be looking at is urines, okay? So I would, if I'm starting with anaerobe culture, I will be looking at internal specimens much more readily or earlier than looking at urine cultures. I just see two more questions that have just popped up in the chat as well. He asked, we frequently isolated Pseudomonas aeruginosa from urine. Please give, yes, it's common, particularly if the patient is catheterized, okay? So Pseudomonas aeruginosa and also maybe Acinetobacter are a common, let's say, nosocomial infection, not only in Myanmar, all around Southeast Asia and perhaps globally as well, okay? And these are common colonizers, particularly if the patient is catheterized. Now, the treatment if the patient is catheterized, of course, if we're identifying these organisms, is first to replace the catheter, okay? So that's the first option here. And it's because it is waterborne, Pseudomonas aeruginosa and Acinetobacter, it is usually a common cause of nosocomial infection in an institution. So we're going to find it commonly in our ICU patients, particularly if they're catheterized or anything else. The next question. Okay, in the case of neonate patient, we can't get, of course not, we can't get midstream urine, a proper sample collection. Should we report significant growth of skin flora as a pathogen? Most of the time I inquire about patient's condition, and if this patient is seriously ill condition, I report coag negative staph as a pathogen. Is it correct or not? Okay, so absolutely right. Neonatal patients and urines are a headache. Now, typically there'll be a bag collection. Okay, so a bag collection is a bag is placed around the genitalia of the child, waiting for them to urinate, and of course the urine then sloshes around the genital area, collecting all of the genital normal flora. Okay, so we have to be really careful about the organisms that we're reporting from a bag collection from a neonatal specimen. Okay, if I report coag negative staph, is it correct or not? I would not reported as a pathogen because we have a lot of coag negative staph around our genitalia area. So the first thing is we're going to have always mixed growth. Okay, and we have to look for the most significant organisms. I would definitely report As per the earlier slides, any gram-negative Staph aureus, go back to here, back to our table of our most common pathogens. Here we go. Any gram-negative organisms, Staph aureus, Enterococcus, beta hemolytic strep. Hopefully you'd never find a Neisseria gonorrhea in a neonate. I would be very cautious about reporting coag-negative staph, and in reality I would report it as mixed normal flora, and same with yeast as well. Okay, but gram-negative Staph aureus, Enterococcus, beta hemolytic strep is definitely reportable. Okay, not coag-negative staph. It's always a nightmare to report bad urines from neonates, and here we seriously have to sift through the normal flora to find if there is a pathogen, number one, and then if it's in significant numbers. Okay. Another question just popped up. Oh, good, a couple more. We report Staph saprophyticus, yes. Is it correct? Or yes, it is. So Staph saprophyticus is one of the other staph that we should always report if it is significant, that is, if it is greater than 10 to the power 5 colony forming units, yes. So the answer for that question is definitely yes. It may be a contamination if it is less than 10 to the power 3, but that's the same for any other gram-positive organism, okay? If Aeromonas hydrophila is isolated from a urine, please, yeah, okay? So Aeromonas is one of the gram-negative organisms, so if it is greater than 10 to the power 5, I would report it as well, okay? So any gram-negative bacilli, if it is greater than 10 to the power 5, and if it is only there as the main pathogen or as part of one of two, the answer is yes. And we have a nice thank you and a heart from Dr. May. Okay. Shall I continue before we have our mid-morning break? What says the team?
Student session မသွားခင်မှာ break လေးယူမှာဒါမှမဟုတ် student session ဆက်ပြီးသွားလိုက်ရမှာရှင့်
ဆက်ပြောလိုက်ပါ
Hello. You want the break 10 minutes? 10-minute break or would you prefer? Or you want to continue?
You asked them, but no response, right?
There's no response.
Please go to
Please continue.
Okay.
Okay, here we go to the weight of bed in sputum.
Okay, so I've been asked to continue. So our next topic is regarding sputum cultures, and not only in Myanmar, all the countries I deal with, they reluctantly confess that they sometimes have some problems, okay? So again, my reference here is not from my company. I'm using an impartial Clinical Microbiology Procedures Handbook, the 5th edition from 2023 from the American Society of Microbiology here, okay? So I'm trying to give you the international standards so that you can follow their guidelines. I forgot to mention earlier as well, so we are quite willing to give you these presentations. I'm very, very much in favor of free education in any method possible, okay? So I will leave these presentations with the Okatiri staff, and they can distribute as they like, hopefully to everybody, all of you, and you can use it for internal training or as you like, okay? So sputum, or Lower respiratory tract specimens are quite varied, and I only have approximately 1 hour to talk, so I chose primarily to talk about sputum as a representative sample of lower respiratory tract specimen. I will just touch on 1 or 2 other specimens as we go along, but it normally requires more time to discuss other lower respiratory tract specimens. Okay, so the most common lower respiratory tract specimen is sputum here, and the samples depend upon the symptoms and conditions of the patients, and the results are strongly linked to the specimen quality. Just show my laser pointer again. Okay. And sputum is one of the specimens that any lab could reject if they choose to here. And we'll talk about the conditions of rejection coming up. Now, commonly, the specimens or the pathogens are divided into community-acquired pneumonia or hospital-acquired pneumonia, and we typically have different pathogens which are representative of community-acquired or hospital-acquired pneumonia. Pneumonia or acute pneumonia less than 21 days often present with a cough, a productive sputum, dyspnea, wheeze or chest discomfort, and these may be not specific to a pneumonia alone, but may be representative of many other conditions as well. The different types of lower respiratory tract specimens, of course, we have sputum, we have endotracheal aspirates, auger suction samples, lung aspirates, bronchial washings, bronchoalveolar lavage, protected brush specimens, lung biopsy specimens. The most common here being sputum, also BALs or bronchoalveolar lavage, and maybe bronchial washings. Now, these are to be stored at 2 to 8 degrees or refrigerated prior to be sent to the laboratory. And the time frame here we need to process usually within 24 hours. So not as tight as urine, within 2 hours typically, but within the 24 hours. I mentioned beforehand that it is possible to reject some sputum cultures. Now, this is your option. So you may choose to accept all sputum. You may choose to use the criteria issued by the manual of the clinical procedures manual here, or you may choose your own criteria. Okay, so coming from the clinical procedures manual, they say do not reject sputum for culture of Legionella, Nocardia, AFBs, or specimens from cystic fibrosis patients based on any gram stain results. Okay, these are then considered to be major conditions. Typically, we examine 20 to 40 fields from a gram stain smear under low power here and take the average number of cells in representative fields that contain cells. Reject poorly collected sputum specimens more representative of saliva when there is greater than or equal to 10 squamous epithelial cells per low power field in a gram stain. Okay, so they use the cutoff, and this is, I'm quoting verbatim here. So they use the cutoff of greater than 10 epithelial cells per low power field. Now, in my 42 years of doing microbiology, usually I look at the ratio of the epithelial cells versus the white blood cells. Okay, now if there is a predominance of epithelial cells over white blood cells, then it is a criteria for rejection. If there is a predominant number of white cells over epithelial cells, then I would not reject that specimen. And if it's 50-50, then I would accept the specimen as well. Okay, but this is what I'm basically copying and paste directly from the procedures manual. Okay, see the figures for the gram stains examples that are unacceptable, and we have the figures coming up in the next slide. If the number of polymorphs is 10 times the number of epithelial cells, and there are 3+ to 4 plus of a single polymorphotype of bacteria accept the specimen. So if you have a large amount of white cells, then do not reject. So here is some examples. So we have 2 examples of a gram stain. On the left, figure A, excuse me. On the left, figure A is a gram stain smears of a sputum sample on low power and high power on the right, okay? So we can see many epithelial cells, greater than 10 epithelial cells per low power field. And when we go on high power, we can see just an abundance of epithelial cells, okay? So this is consistent with normal oropharyngeal flora, and this sample could be rejected, okay? A second sample here. So here we have a gram stain smear of a sample on the left, low power, and on the right, high power here. And if we look at the high power first, so we can see that the cells that we see in the low power are not epithelial cells, but are mostly white blood cells, okay? So we have less than 10 epithelial cells per low power here. And we can see an abundant amount of organisms as well. And this is consistent with a bacterial pneumonia. Okay, this sample should not be rejected. They suggest the following comment, and as I said, I do not always like their comments that they have. I think that they sometimes are too wordy. I think I like to have more clear, concise, simple comments that convey to the clinician what is going on or what is happening, okay? However, I'm giving you copy and paste or quote verbatim here. They say, when rejecting a specimen for culture, report the following. Quote, the smear contains greater than or equal to 10 squamous epithelial cells per low power field, suggestive of a poor quality specimen. Culture not performed. Please recollect if clinically indicated. Now, I would perhaps have a comment saying something like the specimen resembles saliva containing numerous normal flora. Culture is not performed. Please recollect if clinically indicated. Something like that is perhaps what I would say. Notifying the ordering provider that the specimen would not be cultured the same day that it is rejected, not the day after or days after as well, okay? Or as per your local policy here. Now, as I said, it is the laboratory's decision whether they choose to accept and culture all specimens or reject specimens that resemble saliva. Lower respiratory tract pathogens. So because we have always normal flora, okay, so the question I often get asked, and hence it's listed out here, what organisms are we looking for? What organisms do we need to report the identification and susceptibility? And here, sorry, excuse me, based on the clinical conditions. So cystic fibrosis, often we get many sputum or lower respiratory tract specimens from cystic fibrosis patients here. And here we're looking at predominantly Pseudomonas aeruginosa, Staph aureus, Burkhardius cepaceus species, and also Aspergillus species as well. For laryngitis, bronchiolitis, and it's primarily Mycoplasma pneumoniae, so typically we do not culture for this on routine. Chronic bronchitis, we're looking at Streptococcus pneumoniae, Staph aureus, Haemophilus influenzae, any gram-negative bacilli, or respiratory viruses as well, which is obviously not culturable in a routine laboratory. If we have specimens coming from ICU, very often these patients are intubated, and just like catheterized patients, we can be colonized with our very many gram-negative organisms, including Pseudomonas aeruginosa, Burkholderia cepacia, and in our part of the world, also Burkholderia pseudomallei. For a community-acquired pneumonia, we have the whole range of organisms that may be the pathogens, including Strep pneumoniae, Staph aureus, Haemophilus influenzae, any enterobacterials, or any gram-negative, both the fermenters and the non-fermenters as well. Any anaerobes, both our gram-positive and our gram-negative anaerobes, but usually we don't routinely culture for anaerobes unless on the request. Keep in mind our mouth. We have a whole lot of anaerobes in our mouth as well, so that we have to question whether it is oral contamination or not. Pasteurella species, Legionella species, particularly on request or if there is an outbreak, Mycoplasma pneumoniae, Chlamydia pneumoniae. If on request we're getting no other significant pathogens being grown on our routine cultures here, we might want to look for our Mycoplasma and Chlamydia as well. Chlamydia psittaci, Nocardia species, any respiratory viruses, Pneumocystis duraventii. Now that has recently changed name as well. And Neisseria meningitidis and Branamella catarrhalis. For hospital-acquired pneumonia, a slightly different mix here. So Staph aureus, absolutely any gram-negative bacilli, as mentioned, other anaerobes, but usually we do not routinely test for anaerobes unless on request. Any Neisseria species, Branamella catarrhalis, Legionella pneumophilia, or any other Legionella species as well. So typically it's ideal that the sputum is delivered within 2 hours to the laboratory, if possible. Now I know it's the real world, so very often this is not possible. So otherwise store at 2 to 8 degrees, and we need to know what type of specimen is it, if it is clearly not a sputum. We don't normally look at the volume of the specimen, but we do look to see the color, to see whether it's bloody, whether it's pussy or not. We always perform a gram stain. We may perform a wet mount, and optionally we may perform a Giemsa or a Zeil-Nielsen for AFBs, okay? So it depends upon the request. I'm always amazed. So I'm from Australia, so I've been working in microbiology laboratory for many, many decades, okay? And we used to always liquefy our sputa. And in Southeast Asia, even though I've been trying to educate people for many, many decades, there is almost no laboratory that liquefies their sputa. There's a huge advantage to liquefying the sputa, and it is really, really very simple. There is a product by Merck, and it's called Sputolysin, and this is the easiest way to liquefy. I have to have a correction there. I was recently in Vietnam, and the laboratory I was visiting there, which I think was called 108 Hospital, was a pediatric hospital. They were asking me how to liquefy, so that was good. They were coming forward with that, and they were very, very pleased that I offered them this option here. So there's a product by the Merck called Sputolysin, and this is just a screenshot from their website here. So I don't know who the distributor is in Myanmar, and this is an enzyme which breaks down the mucus of sputum in 10 minutes at room temperature. very, very simple to use. And you just add equal volume of the sputulysin to your sputa, have it on a rocking tray at room temperature for 10 minutes, and all of the mucus is broken down and it does not kill or destroy any of the epithelial cells or bacteria, fungi, or yeast. So you can see that the intended use is for the isolation of epithelial cells, pathogenic or saprophytic bacteria, fungi, and yeast from sputum here. And it makes it much, much, much easier because usually our pathogen is within the inside of the mucus. The purpose of the mucus is formed around our pathogens in the lungs, of course. And so what we are looking for is inside the mucus, and it makes it much easier to detect the pathogen both on the gram stains and on the culture. So I'm forever advocating the use of liquefying sputa or lower respiratory tract specimens here, but I see it's just starting to be adopted in Southeast Asia. Okay, it makes life so much easier, seriously. So typically, the culture media used for lower respiratory tract specimens or sputa, very similar to our urines, is a blood agar or a CNA blood agar plate, McConkey, and always we must add a chocolate, whether it is a non-selective chocolate or a selective chocolate. So if you're making up your own media, you probably just have a routine chocolate plate. That is the very minimum. So 3 plates for a lower respiratory tract specimen is the standard. Okay, just to let you know, there is other media you may select depending upon what you might see in the gram stain. So if we're seeing a lot of yeast, you might add an additional plate to grow a yeast. For example, several gentamicin chlorophenicol plate or a chromogenic plate selective for Candida. You can also have a selective plate for Staph aureus if that is indicated, but really almost 100% of the time, the blood, mac, and chocolate will get you through the day. Depending upon the request, so this is depending upon the request, we may add a Legionella plate. So the typical plate for identifying Legionella is a GVPC plate here. We may also have a selective plate for looking at other organisms if we have a cystic fibrosis patient, such as looking for Pseudomonas aeruginosa or Burkholderia cepacia. And of course, if we're looking for TB, we may have a request for TB or Mycobacterium here, and it's quite common then to set up a Lowenstein-Jensen along with our AFB slides. Now, there is options given by the Clinical Procedures Manual here. They suggest when you're plating out, add a 10-unit bacitracin disc to the chocolate plate to inhibit the upper respiratory tract flora and to improve the detection of Haemophilus influenza. So that will give us a zone of inhibition on the chocolate plate here, which if there is Haemophilus that is hidden amongst the normal flora, it will grow around the bacitracin disc. So it's more easy to see. And they say it's optional to add an oxygen disc to the second quadrant, so that when you're streaking out the plates, that means the second streak of a blood agar plate to demonstrate inhibition by strep pneumonia for the direct detection on the primary plates. So they recommend the use of bacitracin, but they say the use of the oxygen disc is optional. I think anything that helps is good. So I think it's preferable to add both the bacitracin disc and the oxygen disc if you have it available in your lab. So they state adding the oxygen disc is not recommended routinely, but may be helpful for laboratories with large number of specimens for patients with community-acquired pneumonia. Incubate the plates 35 to 37 in CO2. So this is one of the specimens. Obviously, that's just the blood agar and the chocolate plates. We don't incubate the McConkey in CO2 for up to 48 hours. So typically up to 48 hours. If you are having very scant growth of 48 hours, possibly to incubate it another day, up to 72 hours. But even in my experience, 48 hours is usually sufficient unless we have an atypical pathogen here, such as a Nocardia or another fungi. On a chocolate agar, it is a non-selective agar, so this is for the growth of a Neisseria haemophilus and strep pneumonia, but keep in mind it will also grow all of our other oral flora as well. It will grow our gram negatives, so this is where the bacitracin disc comes into play. Now, when I said to place the bacitracin onto the second quadrant, so this is our first quadrant here, this is our second quadrant, it's typically to place it around about here. Now, the blood agar is a chocolate agar is a lysed blood agar plate here, and this is releasing the factor X and V, X being hemin and factor V being NAD, which some Haemophilus need to grow, particularly Haemophilus influenza. We can have selective plates as well. If you're making your own, you're probably not making any selective plates here. So we can have a Haemophilus selective plate, which will only grow Haemophilus. No other gram-positive or gram-negative organism will grow. And we can also have a selective plate for Neisseria. So there's other selective plates for Neisseria, particularly Neisseria gonorrhea, such as New York City or others. And here we have a selective plate containing vancomycin, colistin, amphotericin B, and trimethoprim, which will only grow Neisseria gonorrhea and Neisseria meningitis. This is giving us an example of a chromogenic media for Candida here. In this case, Candida albicans will be blue in color, and we do not need to do any further identification, so we can report immediately that we have Candida albicans. All other Candidas will be pink in colors. So for example, Candida tropicalis, Candida lucuanti, and Candida kefir will all be pink in color. This is just showing us some different Candidas. Some others will be white in color. It's possible to use other selective media. I'm not going to dwell on this here. We could have chromogenic media for Staph aureus here, which will only grow Staph aureus, and this will be pale pink to pink in color after 18 to 24 hours. You could also use mannitol salt agar for the selective isolation of Staphylococcus here, and Staphylococcus will appear as yellow colonies on our mannitol salt agar, but it's not confirmatory. We need to do full identification to identify Staph aureus from other Staphylococci. Now, thresholds for reporting significant growth here. So many questions I get about this. So we'll look primarily at the sputum and the BAL. Okay, so according to the clinical procedures manual here, for sputum, we semi-quantitate the amount of growth. That means we grade it as 1+, 2+, 3+, 4+, depending upon how much growth on the plate. And we use the 4 quadrants to determine whether it's 1+, 2+, 3+, 4+. So if it only grows in this quadrant here, it's 1+, 2+, 3+, or 4+. Okay, it is semi-quantitated, it is subjective. So thresholds for reporting significant growth, they say to report only 3 or 4+ organisms, okay, not less than that. If we have a BAL, which is perhaps our second common organism here, we can do quantitative reporting here by using a calibrated loop or by using a dilution and a pipette. Okay, a quantitative loop will be the most easiest here, using a 10 microliter or a 1 microliter loop here, and they say to report only potential pathogens that are greater than or equal to 10 to the power 4. So that means if there is more than 10 colonies growing, if you're using a 10 microliter calibrated loop. Okay, and now this is not a clear copy and paste from their recommendations, but don't worry, I'm going to make it clearer in a second. So they say to report any amount of the main organisms, Strep pyogenes, group B strep, Francisella, Bordetella, Yersinia pestis, Neisseria gonorrhea, Picardia, Bacillus anthracis, non-candida yeast, molds are not considered saprophytic contaminants, diphtheria, toxin-producing corynebacteria. So I made it much clearer in the following tables here. So a repeat, report any amount of growth. It doesn't need to be above the 3 to 4 plus threshold. Strep pyogenes, group B streptococci, pediatric patients, Francisella, I hope you don't get that, Bordetella species, particularly Bronchoseptica, Yersinia pestis. I hope you don't get that as well. However, it is endemic in some parts of Vietnam, so I get really surprised when I go there. Neisseria gonorrhea, of course, Nocardia species, Bacillus anthracis. We have Bacillus anthracis endemic in Indonesia still, so we still identify it there. Non-candida yeast, any mold which is not considered environmental contaminants here, and diphtheria toxin-producing corynebacteria. In addition, we always report strep pneumoniae and Haemophilus influenza, and we report if it is significant, that means if it is greater than 3 plus or 4 plus, any Moraxella catarrhalis, Staphylococcus aureus, Pseudomonas aeruginosa, Stenotrophomonas morbilia, Acinetobacter species, Burkholderia species, Neisseria meningitidis, any beta hemolytic streptococci, any single species or predominant species of a gram-negative bacilli, and non-diphtheria corynebacteria as well. So they are the reportables. The non-reportables. So we report if we have more than one type of gram-negative bacilli on the McConkey, if it is mixed, we report it as mixed gram-negative organisms. This is what they recommend, regardless of the quantity. 1 plus, 2 plus, 3 plus, 4 plus, more than one type of gram-negative organism. If it is not predominant, report as mixed gram-negative organisms. If report as, quote, isolants consistent with microorganisms encountered in the upper respiratory tract, okay, any virulent streptococci, non-pathogenic Neisseria, any other coroniform bacilli, coagulase negative staphylococci, Rothia species, anaerobes, Haemophilus, which is not Haemophilus influenzae, Eikenella, Agricatibacter, Capnocytophaga, Moraxella, which is not Moraxella catarrhalis, and Enterococci. So these are usually oral contamination, and I would probably put a more simpler comment than isolates consistent with microorganisms encountered in the upper respiratory tract. I would probably say mixed oral flora, something along those lines. Regarding the susceptibilities here, so I'm just showing, we saw the T1, Tier 2, Tier 3 for the Enterobacteriales and Pseudomonas, and when we looked at the urine specimens here. So I'm looking in this case as the more specific sputa or lower respiratory tract pathogens here. So I'm showing the tables for streptococci, beta hemolytic group here, and we see for Tier 1 and Tier 2, which must always be tested and reported. We have clindamycin, erythromycin, penicillin or ampicillin, and tetracyclines here. Our cefotaxime, ceftriaxone, and vancomycin should be held in reserve, along with cefepime, ceftaroline, linezolid, tedazolid, daptomycin, levofloxacin, dalbavancin, oritavancin, and telavancin as well. For Streptococcus beta hemolytic, as I said, I read this thoroughly each year as it comes out, so I'm here to reinforce you. They have some footnotes, and footnote D states, penicillin and ampicillin are the drugs of choice for treating beta hemolytic streptococcal infections. Susceptibility testing of penicillins and other beta-lactams approved by the FDA for treating of beta hemolytic streptococcal infections does not need to be performed routinely because non-susceptible isolates, that is, if the penicillin MIC is greater than 0.12 and the ampicillin MIC is greater than 0.25 micrograms per mil, are extremely rare in any beta hemolytic streptococci and have not been reported for strep pyogenes. If testing is performed, any beta hemolytic streptococci isolates found to be non-susceptible should be re-identified, retested, and if confirmed, submitted to a public health laboratory. Okay, so the comment here, if we are finding any streptococci or beta hemolytic strep, which are non-susceptible, intermediate, or resistant here, then we should double check, we should repeat before reporting and referring to a public health laboratory. For strep pneumonia, it has its own separate table here. So the routine to test and report antibiotics, obviously always penicillin, but also erythromycin, trimethoprim, sulfamethoxazole, cefotaxime, ceftriaxone, plus a combination of the following: meropenem, clindamycin, doxycycline, tetracycline, levofloxacin, moxifloxacin, and vancomycin. To be held in reserve for strep pneumonia is amoxicillin, clavulanic acid, cefepime, ceftaroline, ertapenem, and imipenem, lefamulin, linezolid, cefuroxime, and rifampin. The footnotes for strep pneumonia, footnote C states, penicillin and cefotaxime, ceftriaxone, and meropenem should be tested by a reliable MIC method, okay? That means not disdiffusion, such as described in the CLSI M07 and reported routinely with strep pneumoniae isolates from CSF. Such isolates can also be tested against vancomycin using the MIC method or the disdiffusion method. With isolates from other sites, the oxacillin DIS test may be used. If the oxacillin zone is less than or equal to 19 millimeters, cefotaxime, ceftriaxone, meropenem, or the penicillin MICs should be determined. So it's always advisable to go straight to an MIC method for strep pneumonia for penicillin, cefotaxime, ceftriaxone, and meropenem. Okay. So disdiffusion method is not always reliable for strep pneumoniae. For Haemophilus influenza and para-influenza here, we have only one tier 1 antibiotic, ampicillin, so we must always test for this. But tier 2, we can choose a selection of cefotaxime, cefotaxime, ceftriaxone, ampicillin, sulbactam, or amoxicillin, clavulanic, ciprofloxacin, or levofloxacin, or moxifloxacin, or trimethoprim. And the following antibiotics should be held in reserve: meropenem, ertapenem, or imipenem, azithromycin, clarithromycin, aztreonam, cefaclor, cefprozil, cefdinier, cefixime, or cefodoxime, etc. Now, what is more common, you don't necessarily need to do susceptibility testing for Haemophilus, as the CLSI in their footnotes B and C here. The results of ampicillin susceptibility tests should be used to predict the activity of amoxicillin. The majority of Haemophilus influenza isolates that are resistant to ampicillin and amoxicillin produce a TEM-type beta-lactamase. So, as an alternative, you can just do a beta-lactamase test, and they state in most cases a beta-lactamase test can provide a rapid means of detecting resistance to ampicillin and amoxicillin. Okay, so most laboratories, and I would do this too, is just a rapid beta-lactamase test, and we can report the organism out as beta-lactamase positive or beta-lactamase negative. If it is beta-lactamase negative here, then we can use our beta-lactam antibiotics here. And if it is beta-lactamase positive, then we can avoid the use of our beta-lactamase, our beta-lactam antibiotics. Footnote C says amoxicillin clavulanic, azithromycin, ceftriaxone, ceftinia, cefixime, ceftriaxone, cefprozil, cefuroxime, and clarithromycin are used as empiric therapy for respiratory tract infections due to Haemophilus species. The results of susceptibility tests with these antimicrobial agents are often not necessary for managing individual patients. Okay, so the option is there for you to choose. So they're stating you do not necessarily need to do a full antimicrobial susceptibility workup for Haemophilus influenza and parainfluenza. A beta-lactamase may be sufficient. What not to report, okay? This is very important regarding susceptibility testing, and this may be missed if you are glancing through the CLSI tables, just looking at the breakpoints here, okay? So highlighted here, it states daptomycin is not reported for isolates recovered from the lower respiratory tract because it interacts with pulmonary surfactant here, resulting in inhibition of antibacterial activity here. And if we looked at daptomycin, I only put 2 examples, but there is 4 examples in the CLSI here. They've listed daptomycin for use for all staphylococci here, but a comment not routinely reported on organisms isolated from the lower respiratory tract here. So this is where it should be suppressed here. And also for our enterococci, so daptomycin is indicated for Enterococcus faecium only here. However, there is a footnote or comment not routinely reported on organism isolated from the lower respiratory tract. Okay, so this is a word of warning. We should not be reporting daptomycin at all from specimens from the lower respiratory tract. Interpretation of the results. So a positive culture with strep pneumonia or Haemophilus influenzae, it generally indicates, and this is a quote exactly from the clinical procedures manual, generally indicates infection with that organism or the carriage of the organism may lead to false positive results. So always report strep pneumoniae and Haemophilus influenza. Also, if we have a predominant, when they say predominant, that means 3+ or 4+ growth of any gram-negative bacillus or Staph aureus as well. And also, if it is indicative by the gram stain, that means inclusive of predominant white cells here and not a predominance of epithelial cells. A few things they say, although published guidelines by several expert groups are not in agreement regarding the clinical utility of sputum bacterial cultures for the diagnosis of community-acquired pneumonia, the culture of lower respiratory tract specimens is recommended in patients with healthcare-related pneumonia or VAP, that's ventilated associated pneumonia, to determine the etiological agent and guide therapy here. Well, you know, there is obviously going to be disagreements between different groups as well. But however, my opinion, we have, as an inpatient, we have a patient with an infection. I think we have to try our hardest to determine what is the cause of that infection, okay? Bacterial isolates from patient with a healthcare related pneumonia and ventilated associated pneumonia are more likely to have resistance to one or more commonly used agents, and that is definitely the case in our part of the world. So it's more likely to be a multiple drug resistant organism, as it is a nosocomial infection or a healthcare related pneumonia, and therefore we may have to do additional AST testing and use our tier 3 and tier 4 antibiotics. Limitation. So a negative bacterial culture does not rule out a lower tract infection. Keeping in mind, we could have an infection with atypical organisms such as Mycoplasma, Mycobacteria, Legionella, viral cause as well. The primary pathogen is frequently not recovered from a patient with pneumonia, either because they've already been started on antibiotics when sample is taken or collected, or because they have an infection with another type of organism, such as a virus, a parasite. It could also be a parasitic infection, particularly in our part of the world, fungus, a mycoplasma or mycobacterium that will not be recovered by routine bacterial culture and usually requires a separate test once there is a negative bacterial culture result. Some primary pathogens of pneumonia will not grow on routine culture media, such as Legionella, of course, viruses, fungi, mycoplasmas, and mycobacterium. So here, if we do not have a culture positive result the first time, the clinician and the laboratory should think about some of these alternative causes of pneumonia. False negative bacterial cultures may result from improper collection, or that usually means a saliva collection full of oral flora as well, prior to antimicrobial therapy and or delayed transport of the lower respiratory tract specimens to the laboratory, where we can have the normal flora overgrowing the pathogen. Okay, so again, if it is delayed, it being delivered to the laboratory, try to keep the specimen, the sputum, 2 to 8 degrees or refrigerated and sent to the laboratory and set up within 24 hours. Contamination of a lower respiratory tract sample may also occur by leakage during transportation, but that's the same for any liquid sample in a sterile container. You know, we are also able to reject specimens that are leaked as well, particularly if there's any risk of contamination from the environmental. Okay, so always samples should be sent in a biohazard bag. But I know in this part of the world and some other Southeast Asian countries, the concept is still quite new, and very often the samples are just sent as is. Okay, and good. I think I'm finishing at a good time this morning as well. So that's what I have for you today on specimen, sputum specimens here. So let me just escape from the presentation, see if we have any comments or questions. I will just mute my mic for a minute, okay, to see if anybody's brave enough to ask any questions or to type anything into the chat. So I'll just go on mute for a second.
Student နဲ့ပတ်သက်ပြီးတော့မေးခွန်းလေးရှင်ပြီးလို့ရပါပြီရှင်မိခွန်းလေးရှင် unmute လုပ်ပြီးမေးလို့ရပါတယ်ဒါမှမဟုတ်လည်းချက်ပေါက်မှာစာရိုက်ပြီးမေးလို့ရပါတယ် ရာတို့ဆရာမတို့မိကုံးလေးများရှိလို့ရှိရင် unmute လုပ်ပြီးတော့မေးလို့ရပါတယ်ရှင် Yes.
Perhaps I don't. Sphingomonas is isolated from sputum culture. Is it definitely yes? Definitely yes. So this is a very, very common, also nosocomial infection, particularly on patients that are intubated, particularly our ICU patients. So the answer is definitely yes. For endotracheal tube samples, should we use enrichment media for good isolation of bacteria? So you should be using chocolate, and that is an enrichment media. Okay, so again, there is perhaps a insufficient use of chocolate media in Southeast Asia in general, also in Myanmar as well. So I would say the very minimal for all lower respiratory tract specimens is a blood agar plate, a McConkey, and a chocolate, and that is considered an enrichment media, which will grow both our or all of our non-fastidious gram-positive and gram-negative organisms, but should also grow our fastidious organisms as well. So always, I can't advocate enough for the use of a chocolate agar. Okay, I was at a laboratory yesterday, and which I've been visiting for 25 years in Myanmar, and surprising, they confessed that they have never grown a Haemophilus influenza, which is kind of sad, kind of sad. So it's very important to use a chocolate agar to place the plates in 5 to 7% CO2. If it's possible, for respiratory specimens, both the blood agar plate and the chocolate, or if space does not allow, and very minimally, the chocolate agar plate must be placed in 5 to 7% CO2. I have a question from Mandala Lab, which says, please kindly explain about inducible clindamycin resistance, okay? And actually, I'm going to explain about that in the next presentation, okay? So it's coming up. Okay, it's coming up. I'll explain how it works, okay? And perhaps you were asking us the other day about that. Okay, they all shall be revealed about clindamycin, inducible clindamycin resistance in the next presentation. Good question.
Any question?
Well, then perhaps now is a good time to take a break. We shall resume again, let's say at 11 o'clock. Yes, and I think we are just on perfect timing this morning for the length of the presentations, okay? I will leave the camera on, but I will go on mute here. I too will have a break, and we will resume at 11 o'clock, okay?
One more question.
Hey.
Is it necessary to utilize this company? Well, it's not necessary. It is nice to have. It makes your life so much easier, and also makes finding the pathogen easier. It makes performing the gram stain, both inoculating the smear and reading the gram stain, because the problem with the gram stain with unliquid, non-liquid sputa is that you'll get clumps. And so you'll get clumps of mucus here. And so you can have variation in the gram staining, number one, and then it makes it more difficult to read. So for the purpose of the gram stain, it is much easier. And also for the culturing as well. So usually the organisms we're looking for.
Hello, Blue Miyama.
We have somebody real time.
ဟုတ်ရပါပြီteacher ဟုတ်ရပြီရှင်
So good morning, Mr. Brett Crawley.
Good morning, Dr. Kim. How are you today?
All my microbiologist colleagues.
Yeah.
I'm Dr. Pintechi, microbiologist from Mendeley. I think I'm your old friend.
Yes, I remember you.
So first question is, what is the most suitable stain to detect common fungal pathogens from sputum?
Fungal
What
pattern.
is the-
Okay, so first off, routine gram stain, okay, and then if we see any mycelial hyphae, okay, and then the most common stain is our KOH. KOH stain usually after it's been cultured. Sorry, excuse me. But even in a routine gram stain, directly from the specimen, we will see we'll see either yeast if it's there, or mycelial fungi if they're there as well. Okay, and if we are seeing either yeast or mycelial fungi, it is possible to add an additional plate if you wish to. Okay, they will grow usually quite easy on a blood agar plate, but the problem is so will every other bacteria. Okay, so if you would like to isolate either yeast or mycelial fungi, okay, then I would choose a subarachnoid gentamicin and chloramphenicol plate. In addition to our blood agar, McConkey, and chocolate, okay? So that is depending upon observation on a gram stain.
So is it enough on using with gram stain and KOH preparation to detect fungal pathogens?
It is the starting point. No, I'm not going to say it's enough, okay? But as I said, it also comes down to reading of the blood agar plate if a separate subarachnoid gentamicin chloramphenicol plate was not set up. But then anything that grows on your subarachnoid gentamicin and chloramphenicol plate will either be a yeast or a mycelial fungi, okay? And thereafter, identification has to be done on that, okay? Again, we can also have contamination, oral contamination, particularly with Candida species here. So we're looking at significant growth, 3+, 4+ growth on our subarachnoid plate here, and I would not report just a 1+, 2+ Candida growth, okay? Because it is a common oral contaminant, okay?
And first, I would like to express my gratitude for your training today and thank you for meeting with you. The question is not concerned with urine and sputum sample, but I think you will kindly allow me to ask. Previous week, we had encountered Bacodaria pseudomeli, 93% probability from pus from left knee joint of 48 years old male patient. But there is no antibiotic for it in CLSI guideline. So I would like to know the reason for that. And I report back surgeon what antibiotic he can use after seeing in Google.
Okay.
So am I right? So what is the reason in not contributing in CLSI guidelines?
Actually, there is in the CLSI guidelines, but not in the M100. It's in the M45. And in the next presentation, I will talk about Burkholderia pseudomallei susceptibility testing, okay? Because that's one of the common questions I had from many people in Myanmar as well. And I think it's very important. It's a very serious pathogen. And I think we all should be aware because we are unable to do susceptibility testing at this stage with the VITEC system. So we need to be able to know how to do susceptibility testing of Burkholderia pseudomallei, and hopefully you don't get Burkholderia malei, but also malei as well. But I'll be discussing that in the next presentation, okay?
Thank you.
Let me see what other questions. Is there any chemical alternative to commercial sputulizer? Yes, there is. There is the NALP method, the NAC. Oh, I'm going to have to. It is one of the same methods that we can use for decontaminating sputa for TB culture, but the problem is it is too harsh. It also destroys, and it's designed to destroy routine bacteria and just to keep our mycobacterium alive, whereas the sputulizer is keeping all of the organisms alive, both the oral contamination, as well as our routine bacteria, as well as our mycobacteria as well. Regarding the alternative to commercial methods, they are usually very cumbersome. We usually need to do homemade preparations and required to buy separate powdered chemicals, okay? So the answer is, there's one called NALP OH. I would have to search for the method right now because I know this because this was in discussion quite recently with a customer in Vietnam, and they were looking at this method. And when I mentioned earlier that I presented to them an option of using the sputulizer, they really liked the idea because it was ready-made rather than them making up their own NALP decontamination method. But if you would like further information, I will look it up and we can send it to you later. And I would advise just asking Kim from Biomeria, and she will remind me in the future to give you that procedure, okay? Okay. Patient with necrotizing staph hominis, if I said pus. Okay. Okay, so it's not sputum. I would say yes, definitely. So any necrotizing tissue infection, soft tissue infection here is usually a combination of maybe a number of different staphylococci and also strep pyogenes, typically strep pyogenes, and usually a third organism, which is usually an anaerobe, okay? So necrotizing infections are always serious, and so the answer is staph hominis could be a skin contaminant, but in this case, you normally need to look for any staphylococci, any beta hemolytic streptococci, particularly strep pyogenes here, and also you need to look for anaerobes on this specimen as well. Okay. Dr. Kin, I saw you freeze for a minute there, and I explained we'll talk about the susceptibility to Burkholderia pseudomallei in the next presentation. Are you okay with that? Maybe still frozen. Are we good for a break now? Maybe we'll start at 11:10. Restart? I need a small break. Yes. Okay. I will mute you. Feel free to continue to put your questions in the comments and we'll address it later. Okay. We'll take a 10-minute break and restart then. Okay. See you shortly, everybody.
အားလုံးပဲမင်္ဂလာပါရှင်နောက်ထပ် session လေးကိုဆက်လက်ပြီးတော့ဆွေးနွေးသွားမှာဖြစ်ပါတယ်ခေါင်းစဉ်လေးကတော့ဒီ microbiology နဲ့ပတ်သက်တဲ့ပေါ့နော် Vitek နဲ့ပတ်သက်တဲ့ error လေးတွေကိုဘာကြောင့်ဖြစ်လဲဘယ်လို troubleshoot လုပ်ရမလဲဆိုတဲ့အကြောင်းလေးကိုဆွေးနွေးသွားမှာပါဒီမေးခွန်းလေးအများစုကတော့ပြီးခဲ့တဲ့တစ်ပတ်ကကောက်ထားတဲ့ Google survey ပေါ်မှာမူတည်ပြီးတော့အဲ့ question လေးတွေပေါ်မူတည်ပြီးတော့ဖြေသွားမှာဖြစ်ပါတယ်ဆွေးနွေးသွားမှာဖြစ်ပါတယ် So I would like to invite for the sessions of discover inside or automated microbiology to discuss and invite the speaker Mr. Broccoli to discuss about this one.
Okay, I'm back again. I hope all of you are back. So a week or two ago, many people were given a survey of all of the questions, problems, things that you'd like to be addressed. So in this presentation, I'm going to address the majority of your questions that you proposed to us. And nothing too unusual, but there was a lot of them. So I grouped them into different topics, okay? And we're calling it Insights of Automated Microbiology, but also covers just anything that you've inquired about regarding microbiology here. I would just start off with some general, and then I'll hit the topics and the questions that you've asked, including the susceptibilities of Burkholderia pseudomallei, including the inducible clindamycin resistance, etc. Okay, so let's start off a little bit general here regarding the Vitek 2. So to get the best quality results out of the Vitek 2, like any system, anything can go wrong at any time. So it's always to be aware of the quality of the reagents you're using, you know, the expiration date. Now the cards will automatically be rejected if they are expired, okay? The expiration date from manufacturing is typically 18 months from the day it is manufactured. So hopefully when you get the cards, you should have close to 12 months expiration date on it. Can't guarantee that because it also depends upon the supply chain here, which I hear has some difficulties as well. Regarding the card, of course, ensure that the plastic tape covers all the wells and the cards are filled properly. Most of you have a Vitek 2 compact, okay? So you can visualize or ensure that the saline is lowered after the card is filled and ensure that the tube and the barcode is in the right position, okay? And I have been guilty of this beforehand. Also ensure that the cards are not accidentally frozen. So in laboratories that I've run, if I place the cards in the bottom of the refrigerator, sometimes ice builds up around and you're not aware because it's right down the bottom of the refrigerator and stuff like this. So be careful that they're not accidentally frozen, and if they are, they're brought to room temperature prior to using the cards. And again, quality control, always, always, always. It's recommended, and I'll talk more about quality control coming up as well. In the ideal world, in the ideal lab, it's always good to run quality control weekly for all of your systems in the laboratory, not only in the Vitek. I'll talk about card terminations also in this presentation as well. The saline in the dispenser, it's critical. We dispense saline for all of our results. That's the identification and the susceptibility. So always make sure that the saline is sterile by performing routine sterility checks, preferably weekly. I was in a lab the other day and they said they were performing it twice weekly, and I'm going, excellent. Excellent, you know. And if you're making up your own saline, so it's possible to either use commercial saline or homemade saline here, make sure it's with the correct pH, so that's between 4.5 and 7, and you're using 0.5 0.45% without dextrose, okay? I'll tell you a true story here. I had an urgent call from a hospital in Malaysia some years ago on a Saturday morning, and basically they were saying all of their results from the Vitec were useless, okay? They are quite a large hospital, so this is Hospital Kuala Lumpur. It's the main public hospital in Kuala Lumpur here, and they have two Vitec 2XLs, okay? And they're putting up more than maybe 150, 200 cards per day, okay? And all of their results were useless on the Saturday morning, and I'm scratching my head and saying, well, what happened between Friday and Saturday? So they told me they ran out of saline, okay, and they didn't have any other Bimeria saline in their lab at the time or stock. So they went to the local pharmacy and grabbed the saline from the local pharmacy. So I'm thinking they used the wrong concentration of sodium chloride here. So I asked them to take a picture of the bottle label here, and when they took a picture and sent the picture to me, they had 0.45% sodium chloride, which is correct concentration, but it was with dextrose or glucose, and bacteria love to grow in glucose. So what that meant is with all of their biochemical tests for identification, they had all of the reactions positive and hence had no identifications and hence had no susceptibilities, okay? So something little like that. They asked me what they can do, and I said, well, obviously to change the saline, right? And they had to reset up all of their organisms from the Friday. So they had double the amount of work to do on the Saturday, okay? It's recommended to autoclave the dispenser when changing the saline bottle. So it's best to have more than one dispenser. Many labs just only have one. So, and we'll talk about autoclaving in a minute here, and ensure they have the correct adapter for the bottle neck. Ensure we're only dispensing 3 mils. So I've seen some labs try to dispense 2 mils and it doesn't fill the cards, and then the cards get rejected or ejected out of the instrument, and you waste the cost of a card, which I know in all countries is much more expensive than that 1 mil of saline, which the lab was trying to save money on, okay? If you're making up your own saline, do an antimicrobial activity check, and I'll explain how to do that coming up as well. Regarding the plates, now we say this, or I have to say this, okay? Use validated media, and the way you can check that you're using validated media, it's in our package insert, okay? Or our EIFU, that's our electronic instructions for use, which is our package insert, okay? And correct that and check that you're using fresh culture, not that it's been sitting on the bench over the weekend or over public holidays or anything like this. If you're not sure, do a subculture, okay? So this is the requirements, the culture requirements from our package insert for our identification cards here. So this is covering all of the common media. You're probably using a lot less media than this variety, no problem. But you'll see that we have all of the common media here. I have to put on my laser pointer again. Tryptase soy broth, Columbia blood agar, McConkey, Cled, chocolate, etc. All of the common ones, Hectone you might be using, XLD, Salmonella, etc. For our gram-negative organisms. And for our susceptibility cards, again, common media is our tryptase soy blood agar, our Columbia blood agar, McConkey, and some of the media specific to us. That's usually not a problem. Now, for those that don't know, I've also added, where can you find the package insert, okay? So we have a website called the Resource Center, And since we have a lot of people here from Myanmar online now, I thought I'd just remind you so that you can look up any document from our company at any time. So the website or the URL is https://resourcecenter.bmaria.com here. Once you enter that, if you do not have an account, you can create an account just by clicking on sign up and register yourself here. It's free, it's no charge. We just ask for basic information like what is your email address, you have to create a password, what is the name of your institution as well. There afterwards, after you have an account, you can just enter your email and password, and you can be kept logged in as well, so that you don't need to re-enter it multiple times. Then click log in. Once you log in, the easiest way to look up any document is to click on the product search by text, product code. You probably don't know the product code, so I've just free text, for example, AST ST03, which is the name of our streptococcal susceptibility card as an example here. And then a window will pop up offering you the package insert in either English or in French, okay? I'm assuming most of you speak English, okay? Possibly not many of you speak French, so here we can download it by clicking on this download button here, and it will download in your browser, and it then open up as a PDF. All of our documents are PDF. Okay, so that's just to remind you, if you don't already have an account, that you can look up any documentation for any of the bmaria products there as well. Also, when we're troubleshooting, we also like to check the workflow, okay, make sure the operator is performing everything correctly. So we need to have isolated colonies, so we need good streaking to get the isolated colonies. Our preference for making the suspension is with a sterile loop. Some labs use sterile cotton swabs. Now there's variation in cotton swabs, variation in quality of cotton swabs, and I find that we have more contamination using cotton swabs. That is, we have more unidentified results than when we use a sterile loop. Okay, it doesn't matter if it's reusable or a one-time use loop. Okay, correct McFarlane. This is particularly important for susceptibility testing. As I said, the volume of the suspension should also be 3 mils as well, and to mix the suspension well. So I had the questions over the last couple of days about vortexing. It's not recommended to vortex an uncapped tube in microbiology. So if you're using a tube with a cap, you could vortex, but if you're using a tube without a cap, I do not recommend vortexing at all. Use the loop to mix, or if we're transferring an aliquot from the ID tube to the susceptibility tube, go up and down with the pipette 3 to 4 times to make sure it's mixed well, and load the cards into the instrument in less than 20 minutes, okay, preferably. Now, your common questions grouped into the different topics, so hopefully I'll cover the question that you asked, okay? I'm not covering supply chain questions or engineering questions as they're out of my control, okay? But all of the ones, majority of them concern me, or majority I can answer, so I will answer your questions. These will be jumping around because they were just in the order that I was presented the questions, so forgive me there. And I've grouped them into different topics. So the first topic was unidentified results, okay? Everybody hates unidentified results, myself included, okay? It wastes time, it wastes money, and it's frustrating, of course. So the reason why we could have unidentified results, the most common is contamination, and we'll talk about what are the sources of contamination in a minute. But it could be from mixed colonies on the plate, it could be from old cultures, it could be the incorrect starting McFarlane, it could be a gram stain error. over decolorizing the gram stain or under decolorizing. So I think I have a gram positive organism, but I really have gram negative and vice versa. It could be the wrong organism loaded into the wrong card. For example, I remember a laboratory once inoculating a gram negative identification and susceptibility card with a Haemophilus, right? So they should have inoculated a NH card. They didn't realize it was. They did a gram stain. It was a gram negative Coccobacilli, of course. And so they thought, okay, we'll just load it into the gram negative identification card. It could be because the organism is not in the identification database, okay, if it is a newly discovered organism, or if it is an environmental organism. So our database is predominantly designed as a clinical database. And the other thing is we could have damaged cards or something. Not likely, but got to have all the options. So I highly recommend if we have an unidentified result, the first thing is you check the positive biochemical reactions here and you physically count how many are positive here. Now, this is not coming from my company. This is a tip or trick that I discovered along the way as being a previous user of the Vitek 2 systems. So typically, if there is more than 30% positive reactions, it indicates that we have contamination. Now, the contamination, it can come from a number of places, okay? And if I have less than 30% positive reactions, it may indicate that I have low reactivity or a non-viable organism may be overexposed to antibiotics. So you simply have a look at the biochemical results here and you simply count. So we have approximately 64 biochemical tests, okay? And you just come along and count the positives. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So I have 30 out of 64, which is close to 50%. You don't need to pull out your calculator or anything like this. So in this case, I have an unidentified results, most probably due to contamination or by loading more than one organism into the card, okay? Nothing to do here. If you've done a purity plate, check the purity plate to see if you can identify 2 or more different colony types. If you have not, we may need to go back to the original plates, observe them, possibly subculture and replete. Nothing to do here. As I said, good streaking is going to save you time and money. Contamination, now the contamination can come from anywhere, but very often first think about the saline and the dispenser. Perform a sterility check if you haven't done so recently. If it fails, discard the saline and autoclave the dispenser for 121 degrees Celsius for 20 minutes at the very least, okay? Somebody historically has asked me, can they autoclave the saline and then reuse the saline? But the answer is no. And the reason is, even though by autoclaving we have killed any bacteria there, but by bacteria or yeast growing in the saline, we now have additional protein and we have any other metabolites that the bacteria have been producing while they have been growing, bacteria or yeast, okay? So we'll change the biochemical properties of each individual biochemical test. So the answer is no, we cannot. We must discard. Keep in mind, saline is the cheapest component of the whole system here. Also, if you're making up your own homemade saline, here we can perform an antimicrobial activity, and I'll explain that in a slide coming up. Also, contamination can come from mixed colonies on a plate, so good microbiology streaking and handling techniques is very important here. Poor microbiology handling techniques cost time, cost money. Also, loop handling, if you are sterilizing your loop, make sure it's cooled down and we're not killing the organism by using a too hot a loop. the tubes, handling of tubes as well. Now, I've seen some operators over-handling, over-touching everything. So try to handle everything once, not by picking things up, putting things down, checking this, checking that, etc. Card handling as well, also the environment. Now, true story again, I had a laboratory in northern Thailand that had a lot of unidentified results, okay? And I couldn't work out why. And so I went to visit them in northern Thailand here. And it was a very, very dirty laboratory, lots of dust and dirt. And they were operating directly under one of those window box air conditioning. And the air was blowing directly into the face and around where they were setting up. Now, air conditioning are very, very dirty, okay? They contain a lot of bacillus, which is what they were growing on all of their plates, okay? So the simple thing is, they said, what is the solution here? And they had another bench away from the air conditioning. So I just recommended they work away from the air conditioning. Same thing if you have ceiling air conditioning as well. It's recommended not to work directly under the airflow. Okay. Sterility check. To do a sterility check, it's very quick, easy, may not be quick. We dispense 3 mils of saline from the dispenser because we also want to check the dispenser as well, directly onto a blood agar plate, roll it around, pour off the excess, incubate the plate overnight, 35 degrees. And if anything grows on it, a bacteria, a fungi, a yeast, 1 colony, 100 colonies, whatever, then it's contaminated. Throw away the saline, autoclave the dispenser, take a new saline, and continue. Okay. Antimicrobial activity check. Nobody knows how to do this. So this is a way of telling whether there is something in the homemade saline that is killing the bacteria. Now, I've come across this about 4 times in Southeast Asia. So this is where people are making their homemade saline from their sterile distilled water, which is also made in their lab as well. And the sterile distilled water is containing too high a concentration of fluorine or chlorine. Okay, so there's 2 ways, is to take a Mueller-Hinton plate and inoculate with 0.5 methylene of an E. coli, which is susceptible to all antibiotics, such as the ATCC 25922, but it doesn't need to be an ATCC strain. It could be a patient E. coli, which you've proven to be susceptible as well. Take a sterile filter paper, dip it into the saline to be tested, and then inoculate the filter paper on top of the E. coli, incubate overnight, and if we have any zone of inhibition, it indicates we have antimicrobial activity. So it's like the reverse of a disk diffusion susceptibility test. Another method, which I prefer personally, it's almost exactly the same. We take a Mueller-Hinton plate, inoculate with 0.5 methylene E. coli, which is susceptible to all of the antibiotics. ATCC 25922 is an example here. Cut a hole in the agar with a sterile scalpel blade, okay? Usually I cut about a 1 centimeter by 1 centimeter square because I'm just a simple person, okay? I'm not artistic at all, so just anything. And then I fill the hole with saline and then incubate the plate upright overnight at 35 degrees. And if there is any zone of inhibition, it indicates antimicrobial activity. Okay. Mixed colonies. So it's highly recommended, particularly for new users of the Vitek 2 systems, to do a purity plate. So this is where we subculture from the AST tube after the cards are loaded into the Vitek after, because we want to see what has happened precisely to the cards, what has been loaded into the cards. If we have only set up an ID card, then of course we have no AST tube, so we can take an ID tube. We use a non-selective media, typically blood agar here, and then we scan the plate if result is unidentified or otherwise questionable. Obviously, we don't necessarily need to look at the plate or read the plate if we have a good quality results. We recommend this for new users. Some laboratories continue this forever. Okay, so it's your choice. but highly recommended, particularly if we're troubleshooting or getting a lot of unidentified organisms. Old cultures, ideally cultures should be always fresh, 18 to 24 hours old for routine organisms. And if it's not, so if you want to do anything, if I take identification susceptibility, for example, on a plate that's been sitting either on the bench or in the refrigerator, then it's advisable to subculture fresh onto non-selective media and to repeat, okay? If you're not sure of the age or the viability of the organism, you can set up simultaneously, if I take 2-card and puree plate, to have it ready in case you get questionable results the next day. Incorrect starting, McFarlane. Now, you wouldn't believe the number of times I've come across this, particularly with our old density check plus, okay? So it's recommended to perform a QC check at least daily and to clean the optics and tube holder if it is out of range. With our old density check plus, it has batteries. So as the batteries get weaker, we can have our QC check out of range. So ensure also that we're selecting glass tubes when we do the QC check, and we select plastic tubes when we're routinely doing our organism inoculum, okay? Rotate the tubes 360 degrees while reading. That applies to all of our density checks, whether you're using our new density check or our old density check plus, okay? And do not zero on air. So this is what I've seen many people do. You would be surprising. So usually subconsciously, while their right hand is making an inoculum, their left hand is pushing the 0 button, particularly on the density check plus. And this means that your McFarlane inoculum, if you think you've made a 0.5 McFarlane, it will really be 0.2. It would be 0.3 McFarlane lower, okay? Rotate tubes while reading again, homogenize well, mix well. Do not use a vortex unless you're using a tube with cap, and insert and load the cards into the instrument within 20 minutes. Terminated antibiotics. So this was, many people asked about terminated antibiotics, and this is a problem not limited to this area of the world. So there's a number of reasons or a number of scenarios that we might have terminated antibiotics. So first off, it is the scenario where we just have a few antibiotics only being terminated, and some other antibiotics have results. So we could have, typically we have 1 to 3 different growth control wells in the card, depending upon the card type, okay? And particularly Piperacillin tazobactam has its own positive growth control well, okay? So we need to look at the analysis message to find out exactly what is the cause of terminated antibiotics. But typically their messages may say, quote, insufficient growth in the positive growth control well, and this particularly applies to Piperacillin tazobactam. And so we haven't had enough growth, and this usually means that we haven't mixed or we haven't transferred the organism. Particularly, we haven't mixed the organism into the AST tube well, and we have different concentrations of the organisms in the upper and the lower part of the tube. Another analysis message may say, cannot complete incubation extensions. That means that the incubation extension, or it needs to incubate longer than the maximum time. And the maximum time for our gram-negative staph and coccus is 18 hours. And for antifungals is 36 hours, and for streptococci 24 hours. So if the software does not have a final result after 18, 24, or 36 hours, depending upon the organism, then whatever antibiotics are incomplete, it will say terminated as well. Also, another analysis message may be the initial raw value is too low for at least one well, and there is a predefined threshold for each antimicrobial, okay? And that typically means that we did not start off with the right McFarlane strength. Okay, either we forgot to transfer over inoculum or we did not mix the tubes in well enough. Another reason is the power could go down. So I've been in Myanmar for the last couple of days and I've seen the power go down, I don't know, maybe 4 or 5 times already. So I know that's a problem. Now, it's only a problem if the power goes down for more than 45 minutes. So the instrument is going to be reading each card every 15 minutes, okay? And if there is 3 or more data readings that are missing, okay, then whatever antibiotic is incomplete, it will say terminated as well. So for all of our instruments, we supply them with a UPS. So that's a battery backup. So the battery in the battery backup, of course, if it's a new UPS, typically it has a life of about 20 minutes. So that is 20 minutes plus 45 minutes. So if it's a new UPS, and the battery in the UPS deteriorates over time as well. So you might have up to about 1 hour before we have terminated cards if the power goes down and does not come up. Now, it's slightly different if all antibiotics are terminated. So we have a universal positive growth control well, as well as a specific growth control well for individual antibiotics. So if the analysis message says insufficient growth in the positive growth control well, that may indicate that we forgot to transfer the organism to the AST tube. Okay, that is one reason that we don't have growth in any of the wells. It happens. Nobody's going to admit that, okay, but we get busy, we answer the telephone, we need to go to the toilet, whatever happens, okay, we might forget to transfer an aliquot. Also, the same thing, we might have a message that says cannot complete incubation extensions. That means our organism's growing too slow. It may be because the organism has been knocked about by too many antibiotics or antifungals. The initial raw value was too low for at least one well. Again, that's due to the initial McFarlane strength and power going down shortly after we have loaded the cards. So we'd rather see this for all antibiotics if the power has gone down within the first hour of loading the cards into the instrument, okay? And the third cause, if we have random antibiotics terminate, so there seems to be no pattern, sometimes in a gram-positive card, sometimes on a gram-negative card, sometimes on a yeast card, sometimes it's this antibiotic, sometimes it's that antibiotic, okay? It could be 2 major causes here. It could be the leading ledge or the optics, okay? So over time, the optics and the leading ledge need to be replaced. So typically, in my experience, they will have a life of around about 7 to 10 years of age, okay? There's nothing to do here. So if it seems to be random, the first thing you should do is call an engineer to come and check the system here, particularly the optics. The other thing, before calling the engineer, you can clean the optics. Hopefully you're performing routine monthly cleaning of the optics. I've been checking the optics at the laboratories that I've been going to for the last 2 days here. Most of them were nice, but we did accidentally find a smudge of dirt on one of the optics in one of the customers' sites. So it happens, right? Low discrimination, again, like unidentified, nobody likes low discrimination here. And the software will offer a supplemental test, but most people are either unaware of this or completely ignore it, okay? Supplemental test is additional tests, and sometimes they're easy to do, sometimes they're impossible to do, okay? So we can select chosen identification from the drop-down list based on the tested supplemental tests if you can perform it. Supplemental tests are usually found on bMeria's API strips, but we can determine which strips by looking at the package insert. Hence, that's why I also showed you the resource center so that you can have access to the package insert here. Alternatively, check the purity plate purity and if necessary repeat if you can't select one of the offered organisms. So this is an example of low discrimination. So here we have a low discrimination and it's offering us 50% chance of being a Klebsiella pneumoniae ozone or a Klebsiella pneumoniae subspecies pneumoniae, okay? And the supplemental tests are listed down here or also on the lab report as well. And in this case, for those that are new to this here, if it was a Klebsiella pneumoniae subspecies ozonae here, it's offering us two offline tests here. One is a urease, and in brackets, it has 1. And the second test is VP, also in brackets, it has 1. Now, for the VITEP2 software, whenever we have a number in brackets, it always means the percentage that are positive for that test, okay? So if only 1% of Klebsiella pneumoniae ozonae are positive for urease, for example, that means 99% are negative. Now, it is possible to do a spot urease. The spot urease is available on the market, but I don't think any lab in Myanmar has this that I've seen so far. If we have a Klebsiella pneumoniae subspecies pneumoniae here, you'll see that the urease in brackets is 99. So that means 99% of Klebsiella pneumoniae subspecies pneumonia are urease positive. Okay, if you are able to do, for example, a urease test and it was positive, then I would select the organism identification to be Klebsiella pneumonia, subspecies pneumoniae here, and then you should automatically have a susceptibility result coming out. Okay. But the important things to look at the supplemental test, see if there's something you can easily do in your lab. Don't just ignore it, okay? And sometimes they will offer you biochemical tests which are impossible to do in your lab. Now, these are all on our package inserts nowadays, okay? This is another example where we'll have supplemental tests, and this is where we'll have an organism group, say, for example, Acinetobacter baumannii complex. It's okay to report Acinetobacter baumannii complex. You know, if you have no means of further identification, that's okay. But as you can see here, there's actually two very, very easy tests to do here. And it's dividing the Acinetobacters, Acinetobacter pittii, baumannii, and calcoaceticus, depending upon whether they grow at 44 degrees or grow at 41 degrees. So that is what the 44C and the 41C mean. So if you have an extra small incubator, you can set it for 44 or 41 degrees subculture onto a blood agar plate. And if it grows at 44 or 41 degrees, or if it grows at both, you have an Acinetobacter baumannii, and if it does not grow at 41 degrees, you have an Acinetobacter calcoaceticus, and if it grows only at 41 but not at 44, you have an Acinetobacter pittii. So it's not complicated to do, but you may need an extra incubator. I have in my historic lab, tiny incubator, you know, just to hold a couple of plates in or something like that. So this is an example of the supplemental test from the package insert. As I said, some things you can do easily, such as an oxidase test, okay? Every lab has an oxidase test. Other things is the color of the colony. Is the colony purple? You just go back to your non-selective plate and read if it's purple. do we have pyosin pigment or pyrovarin pigment here? So this is the fluorescent green color that Pseudomonas aeruginosa usually produces, okay? Is it methyl red positive, or do you have a spot urease that you could do? Is it yellow pigment, yellow colony? So see if there's something easy to do. If there's nothing, okay. If you don't have it available in your lab, then you could do nothing. You could either make a wise decision, or if it's a complex, just report out the complex. Inconsistent. So what happens if the AES finding says inconsistent? So we need to go into troubleshooting mode. It means that our result is microbiologically impossible. The organism identification does not match the phenotypes that are detected, or we cannot find a matching phenotype for that organism. So we go back to the basics. We need to double check everything. That means check the gram stain. Did we set up the right cards? Check what media the organism grew and what media it did not grow, and what was the atmospheres. Check the organism identification. Was it manually entered? Did somebody guess the organism identification? So if that was guessed or it was done manually, then set up an ID card or use another method for checking the identification. Check for pure culture, the correct media, the age of the organism, the correct inoculum strength, the saline sterility and pH. Always check that first, seriously. Any antimicrobial activity if you're using homemade saline, and the right atmosphere, and also check for human or clerical error. Did somebody just pick up the wrong plate and inoculate the wrong plate into the wrong card? Okay, and then if everything seems to be correct, then nothing else to do here except to repeat the identification and susceptibility as carefully as possible. Okay, so this is an example of an inconsistent result, and the comment which nobody reads says, excuse me, the observed results do not match any phenotype in the AES knowledge base. Verify the organism identification and check the isolate purity. Retest if deemed necessary. Okay. Excuse me. And in this example here, I'm just showing you the AES graphics. In this case, it was inconsistent here for the aminoglycosides. The software could not find a matching phenotype here. If there was a matching phenotype, there would be either 1, 2, or 3 green stars above the phenotypes here, or above the graphics here. So we could not find a matching phenotype with aminoglycosides, and therefore it called it inconsistent. At the very least, we must find the wild phenotype or the intrinsic resistance. Insufficient antibiotics on a card. So many people, not only in this part of the world, around the world, complain about the number of the antibiotics or the choice of the antibiotics. So it is possible to deduce additional antibiotics, and we can do that as one of the configurations in the software here. So this is an example of a result, and if we count the antibiotics here, including the ESBL test, we have 1, 2, 3, 4, 5, 6 times 3 is 18 antibiotics here. It is possible to deduce additional antibiotics, and if I reanalyze the same report here, I would then have a report that looks like this. Any deduced antibiotics would have an interpretation, but no MIC because they were not tested on the card. In this example, I've gone from 18 antibiotics to 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 times 3 minus 1, that's 29 antibiotics, okay? So I have an additional 11 antibiotics in this report with no additional cost or no additional time, okay? So that's one option. No AST results. Again, everybody gets frustrated about this. It should not happen very often, but if it does, some of the main reasons, it could be that the AST results are not claimed. So in our package insert, we list the organisms which are claimed for susceptibility. That means they are FDA approved, okay? Or it could be a new organism. So we have a new organism called Staphylococcus aureus, and this is a new non-human pathogen as well. And it's a newly defined organism. So even though this is in our database for identification here, it is not claimed for susceptibilities at that time or this time, okay? Also, check the specimen type. If it is a sterile specimen, we need to be able to report it. If it is a non-sterile specimen, is the organism significant? For example, is it a urine specimen? Is the organism significant, and do we need to report susceptibilities or not? We will always say, excuse me, we will always say perform an alternative method, and the alternative method is, for example, distribution or e-test or something else like that, okay? Or, and I'm not saying this, but we've learned our trick many years ago. Sometimes it's possible to choose a closely related organism within the same CLSI breakpoint table, where the Vitek software will then give us a susceptibility result. You did not hear it from me. Quality control. Now, we always get questions about quality control, okay? So this is a table called the MIC Reference Guide to QC Frequency in the CLSI M100 S34. Now, the full method of performing quality control is listed in the CLSI M52. Okay, that will give the full. This is just giving us a summary of quality control. Now they state, and I always talk two things. I talk the theory and I talk reality. Okay, so first off, the theory is following them strictly here. And they state up the top here, this table summarizes the suggested QC frequency when modifications are made to antimicrobial susceptibility test systems. It only applies to antimicrobial agents for which satisfactory results have been attained with either the 15 replicate. That means by putting quality control organisms through a system 3 times a day over a 5-day period, or by running quality control organisms for 20 or 30 consecutive test days, okay? So in theory, we're supposed to validate any system by using the 15 replicate or the 20 or 30 consecutive test day plan. And everybody's shaking their head already, I know. And once we've done that, we can step down the frequency of quality control to only run quality control every new shipment or lot number of cards that we receive. Okay, so in theory, so very minimum we should do every new shipment or lot number of cards or other reagent, but also other things that we may need to do when we add a new test here. We need to go back to the 15 replicate plan or the 20 to 30 day plan, or when we add a new antimicrobial to the system here. Also be aware when an engineer comes to repair or update the software or something like this, we need to perform quality control immediately after as well. Always in an ideal world. I know this is not an ideal world. At least you know what the expectation is. Now, in our package insert, these are the instructions in our package insert. And first off, it's the frequency of testing. We are non-committal here, okay? We don't commit to anything. It says currently it is recommended that you use your most stringent inspecting agent guidelines for the frequency of identifying product testing, okay? So it doesn't say strictly when you should do it here, but You know, I've been working in microlabs forever, and I think that it's much easier to do it once per week rather than when a new shipment or lot number arrives. Okay, now to store quality control organisms, here we have instructions on storing short-term and storing long-term. So short-term is to streak it onto a tryptase soy agar plate or slant, incubate for 24 hours, and then to refrigerate for up to 2 weeks. And subculture wants to describe above before you use it. Long-term is to make a heavy suspension in tryptase soy broth with 15% glycerol, and then to aliquot these into various aliquot containers and freeze at -70 to 80. Now we've had the question, what if we don't have a -70 to 80 freezer? Okay, if you only have a -20 freezer, that's the best you can do. Okay, so typically if we freeze at -70, 80, the organisms can be stored for up to about 5 years. And if we freeze at about -20, the organisms can be stored usually between 1 to 3 years. And we just keep subculturing the aliquot until the organism no longer grows. Okay. So we also have some cryo beads, other companies also have, and this is an easy way. So I really love these. To store organisms, and here we have the reference here. This is a device suitable for storing yeast, fungi, and bacteria, including fastidious, including anaerobes. The box contains 64 tubes, and there's 25 beads in a tube. One bead is removed to subculture. Okay, so one of those tubes can be subcultured 25 times with no risk of contamination. They're also color coded, so I like my yeast to go in the yellow, for example, and the gram positives and gram negatives. And here we can store the organisms up to 5 years or perhaps even longer. Now, a question I've been asked on checking my time, running out of time here, quality control out of range. So if you are using Colombia-based agar, it's recommended to try tryptase soy agar subculture here. Repeat with a fresh working ATCC organism from the refrigerator. And perform a purity plate to check for contamination here. No more than 4 weekly subcultures. So the organism should not be kept in the refrigerator for more than a month. Okay. If it still is out of range, subculture a frozen ATCC organism and repeat with the working organism. And it's recommended to use commercial cryobeads or cryobank for long-term storage. And repeat with a twice subcultured frozen organism. If the ATCC organism repeatedly fails, perform distribution or e-test on the same organism at the same time. If both the Vitek2 and the distribution e-test fail, then there is something wrong with your organism. Okay, so throw it away and obtain a new strain. If both the Vitek2 fails and distribution e-test pass, then there's a problem with the Vitek2 system. Please seek technical help. Some common troubleshooting. So here we have the MIC troubleshooting guidelines from the CLSI. So this is in the back of the CLSI M100. Not many people know it is there here. And I'll just give one example. So if we have with our beta-lactam combination agents an MIC that is too low or susceptible when it's supposed to be resistant here, this could be due to a spontaneous loss of the plasmid encoding the beta-lactamase here, okay? So, and it's also giving us suggested actions, obtain a new frozen or lyophilized stock culture. If we have discrepant receptibility results with different methods, so this is a question many people ask, okay? If it's discrepant between Vitek2 and distillation, well, first off, scientifically, they're two different methods. You cannot compare, right? One is an MIC method, one is diameter, okay? One is MICs in micrograms per mil, the other one is in millimeters. So in theory, you should not, but every lab loves to, Okay, so first off, be aware of a few things. Ensure we have recent quality control on both methods, less than a week old. Ensure there's valid zone diameters for the antibiotics in question. Ensure the correct media, pH and depth, and the right antibiotic storage. Inoculate both the Vitek 2s and the plate from the same 0.5 McFarland suspension to remove any other things. Perform a puree plate on the same suspension and compare only the interpretations or categories prior to the AES expertization. Okay. If there are discrepancies here, check on how close the MIC and the zone diameters are to the breakpoints, because with the micro dilution methods, we have a tolerance of plus or minus 1 doubling dilution, and there is no listed tolerance for diffusions from the CLSI. If we're comparing Vitek 2 in E-test, it's a lot more valid because both of them are measuring the MIC here. Things that are unique or different, ensure there's no bubbles under the E-test strip here. And report the E-test up to the next highest doubling dilution. So if we're reading an MIC of 3, we need to report it as 4 micrograms per mil for the E-test. And we have the same tolerance between the two methods of plus or minus 1 doubling dilution. Okay. Subculturing of positive blood cultures here. Many labs, I see, they subculture onto blood agar and McConkey. So always, if we have a positive blood culture, we must do a gram stain. If we see nothing in the gram stain, both I and also the clinical procedures manual highly recommend performing an acridine orange stain. It is much more sensitive than a gram stain, and we can also see spirochetes and other organisms that will not grow on routine media. So highly recommend to subculture a positive aerobic bottle onto Columbia blood agar or CNA blood agar, McConkey and chocolate. Here, always a chocolate for our fastidious organism. And if you have an anaerobic bottle that's positive, exactly the same, except to set up an anaerobic plate in addition to the aerobic plates. And the best media here is shadeless agar anaerobically. Okay, this is a repeat, but I'm just showing you the CLSI M47 second edition as the guidelines about what to set up for positive blood cultures. They're saying the same thing, so I'll skip through this quickly. Organisms that are claimed are listed on the package insert. I just didn't list all of them here for the gram negative susceptibilities here, but if you're getting no susceptibility result, check to see whether it's listed in the package insert or not. If it is not listed in the package insert, then we do not have US FDA approval or to report that susceptibility result. Also in our package insert, we have product limitations here. Again, nobody reads this. So our software is designed, it will not report the combination where we have a product limitation. Again, the product limitation may mean that we do not have FDA approval to report these organism antibiotic combination. I'll just read out the first one. So the amikacin, we cannot report for Acinetobacter baumannii, Proteus vulgaris or Providencia. And so these organism antibiotic combinations here, you'll see no result on the Vitek. Okay, so it's no result. Sure, complain to our application specialist, but do check the product limitations as well. Choosing the right Vitek 2 card here. So the first thing is, do we have a strict anaerobe organism? Most of us are not culturing for anaerobes, so the answer is no most of the time here. Based on the gram stain, do I have a gram positive or a gram negative organism? If it's a gram negative organism, I go straight for the GN card, unless it grows on chocolate alone. If it grows on chocolate alone, then I can set up my NH card because it's a fastidious organism. If it's gram-positive here, is it a bacilli, cocci, or a yeast? If it's a yeast, I go straight to the yeast card. If it's a cocci, I go straight to my gram-positive cocci card. And if it's a bacilli and a large bacilli, and if I can see endospores, then we have a card for bacillus here. I don't think it's currently being used in Myanmar, and we have another card for Corynebacteria, the CBC card. If it's small Coccus bacilli, and if it looks coroniform, we can set up the ANC card, which is our anaerobe or coroni card, or CBC. And if it's non-coroniform, gram-positive or ANC card. Gram-positive AST card choices. So we have a lot of questions about when to set up our GP susceptibility and our ST03 susceptibility. Okay, so if we have a gram-positive catalase positive cocci, staph or related organism, then we always set up our AST GP, and I think you have GP67 here in Myanmar, okay? And if we have a gram-positive catalase negative, so you need to perform a catalase, okay? It only takes 30 seconds here. I highly recommend performing a Landsfield grouping. I think nobody does this, okay? So with Landsfield grouping, the streptococci and related organisms are divided into group A, B, C, D, F, G, non-groupable as well. So for all of the Landsfield grouping, we need to set up the ST03 card. The exception is our enterococci, and enterococci are all group D. So in reality, all you need is group D antisera. You don't even need, I mean, it's nice to have the rest, but if you're just using it to distinguish which card to set up, and again, this is a 30-second latex kit. Okay, somebody complained there was no cephalosporin sulbactam on the ASTN415 card. That's obviously a card that you're using in Myanmar here. And last night I checked all of the cards that we sell worldwide. And we do not have, at the moment, cephalosporin sulbactam on any of our standard cards, okay? And one of the main reason this antibiotic, cephalosporin, whether alone or in combination with sulbactam, is banned in the United States due to the coagulation side effects, okay? We do have this available on some customized cards for Japan, China, India, Thailand, Indonesia, and Taiwan, okay? And this is where I talk about customized card versus standard cards, okay? It is possible that we can make a customized card, but we do need a minimum annual order of 500 boxes per year, and that's the sticking point in Myanmar, okay? Most of your laboratories are not very high throughput laboratories, okay? So usually we can make customized card for high volume laboratories. So this is the US FDA MDRO antibiotics, which have been recently added to the CLSI. So there's a number of new of them. The ones in green, yes, they're in green. We do have available on some of our cards. The one in blue are just too new. They're not yet available on any of our cards. However, something that's entirely new for ASEAN, so just a little bit earlier this year, we have launched the ASEAN MDRO card. So this is the first time I'm mentioning it here in Myanmar. So at the moment, it is not ready to be sold yet in Myanmar. It's not yet launched. It's not yet registered here. And we will introduce this to the local distributor shortly here. So this is available at the moment in the other countries in ASEAN here. And this is used as an MDR code, not for routine use. So this is if we're setting up our routine cards and our tier 1, tier 2 antibiotics are all resistant here. These will contain our tier 3 and 4 antibiotics for our gram-negative organisms, particularly our Pseudomonas aeruginosus and Acinetobacters that are multiple drug resistant or pan-drug resistant, okay? And this is the N439, specifically designed for ASEAN countries here. We had at least one question asking, was it MIC? And so an MIC is the minimal inhibitory concentration of an antibiotic inhibiting the visible growth of an organism here. And in this example here, as this is a manual MIC test here, where we have doubling dilutions of the antibiotics inoculated with our organism and see what concentration we have no visible growth. In this example here, the concentration of 2 micrograms per mil is the MIC for this organism. And the MIC are compared with breakpoint tables, and this is what the breakpoint table looks like here, to report the antibiotics as susceptible, dose-dependent, intermediate, or resistant. Okay, clindamycin, inducible clindamycin resistance. So I have to cover 1 or 2 topics. I know I'm over time. I hope you can bear with me. So this is the test coming from the CLSI, and it is to detect inducible clindamycin resistant staphylococci, strep pneumoniae, and Streptococcus beta hemolytic group. Now, for these organisms, it is known that they may appear susceptible the first time that we test them. And if we treat the patient with clindamycin and collect another specimen in 2 or 3 days and identify the same organism, then the clindamycin will be resistant, okay? So they already have the ability to be resistant to clindamycin, but this gene was switched off at the time, okay? So they have the ability to turn on the gene or the resistance mechanism with exposure to clindamycin. So we have an inducible clindamycin resistance test, which follows precisely the test in the CLSI. And so we have 2 wells, one well for all staphylococci and another well for strep pneumoniae and beta hemolytic streptococci here. And one of the wells, we have a combination of erythromycin and clindamycin at these concentrations. And the other well, we have erythromycin and clindamycin at these concentrations here. The card is incubated and red, and the interpretation from the CLSI is any growth in one or the other well or both wells is indicating that we have inducible clindamycin resistant, and no growth in both wells means that we do not have. That means we can treat. Okay, so we can treat with erythromycin depending upon its individual, whether it's individually susceptible or resistant here. And the VITEC2 will also automatically change the clindamycin result to be resistant if we have detected growth in the inducible clindamycin resistance wells. I hope that's clear for the persons that asked. Burkhardt pseudomalae. So one of the doctors was saying there was no breakpoints in the CLSI. Well, that's not quite correct. There's no breakpoints in the M100. There is breakpoints in the M45, okay, and they have not been updated since 2016. So this is still from 2016 here. So the M45 is for our fastidious organisms, and you'll see first off, there is no diffusion zone diameters. So that is the most frustrating thing. So we have to perform only an MIC method, and at the moment, and it's frustrating for me too, the VITEC2 puts out an identification for Burkhardt pseudomalae, but no susceptibilities. Now, one of the reasons, or the only reason, not one of them, is because our R&D for Vitek is in the United States, and this organism is not in the United States, so it occurs in the soil in tropical countries here. So we have a lot of Burkholderia in Southeast Asia, but we cannot transport this organism to the United States to our R&D facility because it is considered a bioterrorism organism. So we have a lot of them, but we just can't get it to R&D for them to do the workup to have the susceptibilities available on the Vitek 2. However, we do have e-test or the equivalent of e-test available on the market, which is an MIC method. So it is possible, if you have e-test or the equivalent of e-test, to put out susceptibility, some selective susceptibility results here for Burkholderia, amoxicillin clavulanic acid, ceftazidime, imipenem, doxycycline, tetracycline. So there's about 4 or 5 antibiotics that we can release for Burkholderia pseudomallei. Vibrio cholera, I know you're going through an outbreak again. This is also in the M45, and here we have zone diameter, so it's possible, even though the Vitek 2 does not put out a result, it is possible to change the identification in the Vitek 2 to Vibrio parahemolyticus, for example, because it's in the same breakpoint table, because this is the breakpoint table for all Vibrio species, including Vibrio cholera. Okay, so it is possible to change the identification to Vibrio parahemolyticus, get a susceptibility result out that way, or you can do alternate methods such as distribution. Okay, and there's 2 pages, so a lot of antibiotic choices for Vibrio choleras. I'm looking at our team. Do I continue? Staph species. So there's only 3 phenotypes known for staph species. That's a wild phenotype, the acquired penicillinase, and a modification of the PVPs here. Okay, so typically our wild phenotype is susceptible to penicillin, oxacillin, and carfoxylin screening test negative. Acquired penicillinase is resistant to penicillin, susceptible to oxacillin, and negative carfoxylin screening test. And our classical MRSA is penicillin resistant, oxacillin resistant, and positive for carfoxetin. Okay. However, we're finding a lot of this scenario here. Our oxacillin is susceptible and our carfoxetin is resistant. Now, this is due to either a low expression of a MEC-A or a new gene called the MEC-C, okay? And I think we're finding a lot of these in Southeast Asia, not only in Myanmar here. It's stating in this presentation it's uncommon, but I think it's becoming more and more common here. Now, the Vitek will automatically change the oxacillin result to be resistant here. The CLSI says if you can verify with a molecular method. If you cannot verify with a molecular method, then report it as MRSA. Same thing if the opposite is seen, resistant to oxacillin and susceptible to carfoxycin. Again, the Vitek 2 will change them to both report resistant. And again, the CLSI says verify molecularly. If you cannot verify molecularly, report as resistant. Okay. So this is the comment about this here. I'm going to skip that and skip that here. So discrepancies between methods here, particularly if we have a molecular method. This is at the back of the CLSI. So if we have a molecular method and we're looking for MEC-A, I don't think there's a commercial method yet for MEC-C. But so that's the other thing to keep in mind. So if the MEC-A is detected and the carfoxylin is resistant, okay, we definitely have a MRSA. If the MEC-A is not detected and the carfoxylin is susceptible, we definitely do not have an MRSA. But if the MEC-A is detected and the cofoxin is susceptible, then we report it as a MRSA, and the opposite, if the MEC-A is not detected and the cofoxin is reported, we still report it as an MRSA. Okay, so really they're saying if either the cofoxin is resistant or the molecular method is detected, in either case, we report it as an MRSA. We had someone asking about, can we identify germaceous fungi on the Vitek? The answer is no, and not likely to in the future. We can, however, identify it on our Vitek MS Prime. So with our Vitek MS Prime, we have validated methods for identifying bacteria, yeast, mycobacteria, Nocardia, molds, which is our germaceous fungi, mycoplasma, and brucella. Okay, and that's all I'm going to mention about the MS. So I'm going to skip the next slides because I've run out of time. And I think the last thing, and this is just to show that we have a kit dedicated for molds on the Vitek MS. And then the last thing, this is setting up, right? I'm skipping all this. I don't want to show you an MS today. And the last thing that I'm going to mention, which if we had time, and I can't do it at any rates due to I need a VPN connection here, to remind you that all of our systems and equipment can be connected together with a software called the Maestria. We call this middleware, and this can collect all of the microbiology results, including manually entered results. And this is a way that microbiology can now become paperless. So with our new version of Maestria, we can also enter our plate reading. So we don't need workbooks anymore in microbiology if we're using this software here. We can also print barcodes from this software. So it can also, if you are not connected to an LIS, it can be like a microbiology LIS, not the rest of the lab as well. And if anybody would like a demonstration in the future, please contact either any Okatiri or BIM area representative, and we will arrange either a face-to-face demonstration or an online demonstration as you would like. Okay, and I think that's it, and I apologize for going 26 minutes over time. Okay, so it looks like there's going to be two different recordings. So I see that one recording stopped at 11:30 and started again. Okay. Somebody has thanked us, Dr. Ken. Thank you for your attention. And again, I apologize. I can speak forever if you allow me, okay, on microbiology. So thank you very much for attending, Dr. Ken, and your questions earlier. So I know you're probably all hungry and exhausted and maybe information overload, but let's see if anybody has some important questions or comments.
Thank you, Mr. Brett Hawley. On behalf of all participants, I would like to say thank you very much for your interesting and informative presentation, and wishing you to visit Mandalay on your next coming.
Just turned on my mic, a bit of static there. And look, I'm always very, very happy to provide people correct scientific information. I'm not a sales person. I'm not here to sell you anything except to sell you ideas. Whether you implement it in your laboratories, that's another thing, depending upon the capabilities. But I'm always very glad to travel to not only Myanmar, but to all of the Southeast Asian countries to try to lift the quality of the microbiology laboratories, try to inspire you to be able to do better and to inspire your staff to put out the best quality results you can, given whatever constraints that we all have. So thank you very much as well for listening. And I also mentioned we're willing to give out the presentations and the recordings you can download after this event, okay? I'll just go on mute now to see if somebody else has any other questions.
Hello. Hello. Can you hear? Hello. Hello.
Hello, teacher.
I would like to raise one question regarding the colistin resistance. In my lab, there is no colistin sensitivity AST in my lab. Most of the GNB reviews the colistin intermediate level AST. That's why there's are reasons for the colistin intermediate result in GNB.
Sorry, I have to find the right document to answer your question. And I was also confused because I'm not using my computer, but somebody else's, so it has a different PDF reader. So to answer your question, so there's a history behind this. So in 2015, 2016, the world, there was a couple of research papers published to say that we have discovered a new gene for colistin resistance. This is the MCR1 gene here, and the all previous methods except broth microdeletion methods were no longer valid according to both the CLSI and the UCAST, okay? So all tests were not valid, and then quite recently, about 5 years ago, the CLSI has changed the breakpoints, as you can see here. So this is this year's, and you'll see there is no longer a susceptible breakpoint. There is only intermediate and resistant breakpoints, okay? So no longer can we, the world, report susceptible colistin or polymyxin B. In the VITEC, using e-test, and you can see that for distribution is no longer valid at all, right? So we can only report the MIC, and we can only report intermediate and resistant. And this has been the case for about the last 5 years. And of course, the VITEC follows the CLSI precisely. Is that understandable for the person that asked the question?
Thank you. Yes, thank you.
Not good, but that's reality. other questions after section? Let me take group. Okay, it's Kim. Does anybody else have any questions? I know you're probably hungry and want to go to lunch. But reality, both now and in the future, we're here to answer your question, whether they're face-to-face, electronic, email, text message, WhatsApp, any way we like. Okay, team, we good then?
session မပိတ်ခင်လေးမှာတပုံလေးအမှတ်တရတပုံလေးရိုက်ပြီးတော့အမှတ်တရတပုံလေးရိုက်ယူထားကြပါရှင်စင်ပြင်ကင်မရာလေးဖွင့်ပေးပါလားရှင် You stop那接着ပုံလေးရိုက်ရှင်
ဓာတ်ပုံဝင်လိုက်
ဒီ
ကင်မရာနဲ့
ကင်မရာလေးရှင်ကျန်သေးမယ်ကျန်အောင် ကျန်တဲ့သူတွေလေကင်မရာဖွင့်ဖို့ကျန်တဲ့သူတွေလည်းဖွင့်ပေးပါအောင်ရှင်ဟုတ်ကဲ့ကျေးဇူးပါရှင်အချိန်ပေးပြီးတော့တက်ပေးရတော့ကောမိကုန်းလေးမေးပေးရတော့ကောစာပေဖြစ်ပေးရတော့ကောကျေးဇူးတင်ပါတယ်ရှင်နောက်ပိုင်းမိကုန်းနေမေးပြရှင်လဲကိုဥက္ကတိရပြည်ညီမကနေတစင်းဆက်သွယ်ပြီးမေးလို့ရပါတယ် portfolio ဆက်သွယ်ပြီးမေးပြီးတော့ကြံဖြစ်ပေးပါမယ်ရှင်ဟုတ်ကျေးဇူးတင်ပါတယ်ရှင်ဒီနေ့ session လေးအတွက်အဲဆိုရင်ထုတ်လို့ရပါပြီပြီးပါပြီရှင်ကျေးဇူးပါရှင်
Thank you.
Are we done?
Yes.
No. Okay. Okay. So you'll have to say goodbye and cannot unmute now. Oh, So for those that are still here, thank you very much for attending our morning exchange of information, and I'm glad to be back in Myanmar, and I'm glad to see you face to face if I can in the coming days, and I'm sure we'll meet again when I next return. Bye. What my